This is Dr. Brian Durie. I'd like to invite everyone to this special session, Accelerating Toward Curing Myeloma, Emerging Data, New Agents, and an Evolving Treatment Paradigm. This virtual program obviously replaces our normal in-person program. And we're very pleased that so many have decided to sign up for this program. So we welcome you to this today's event. So I'm Dr. Brian Durie, the program chair, based at Cedars-Sinai Outpatient Cancer Center in Los Angeles, and those are my disclosures. We're very pleased to welcome Dr. Shaji Kumar from the Department of Hematology at the Mayo Clinic in Rochester, Minnesota. And he lists his disclosures, which will also be listed as part of each presenter's presentation. So you'll see those again. Dr. Thomas Martin, who is the clinical professor at the University of California, San Francisco, and Associate Director for the Myeloma program there, and those are his disclosures. We're very pleased to welcome Philippe Moreau, the Professor of Clinical Hematology, Head of the Hematology Department at the Hotel Dieu Hospital in Nantes, France, with his disclosures. And Vincent Rajkumar, Professor at the Mayo Clinic, also with no relevant conflicts of interest to disclose. Jesús San-Miguel, Director of Clinical and Translational Medicine at the University of Navarra, Pamplona, Spain, and he's listed his disclosures there, so welcome to Jesús. And so just to go through what will be the format for the symposium today, each topic discussion will include the following. There will be a case presentation with interactive polling questions for you, the audience, immediately afterwards. This will be followed by the presentation of the faculty member, after which there will be a second audience vote on the case questions. After that, you will see how the panelists voted, and that we will have some panel discussion, and then we will be taking questions from you, the audience, and I'll go through that in just a second. Yeah, so polling and questions, how to vote. It's pretty intuitive. When there is a new poll, it will pop up, and you just click vote next to your preferred answer. And then asking a question, again, this will be there in the questions window, and you just type in your question and press submit to send in your question. So first of all, we'd like to test this out with a few basic polling questions, which is what we have been doing for some years now. So polling question number 1, if you could kindly answer: which of the following best describes your role on the oncology care team? Physician, physician assistant, nurse practitioner, pharmacist, or some type of other allied health professional? So please answer that. No music on this virtual platform, I guess. Okay, we should have the answer here momentarily. Okay, we can, the poll is, oh, there we are. Yeah, I'm so sorry. So the poll shows, yeah, 55% physicians, 30% allied health care, only a few in the other categories. Okay. All right, let's move forward quickly here. Which of the following best describes your specialty? Hematology, heme-onc, medical oncology, primary care, pharmacy, or translational science? if you go ahead and vote for whichever best describes for you. All right, so I assume this will be popping up momentarily. Or hematology, oncology, and just a few in the other categories. Okay, so the third polling question: which clinical setting best describes your practice? Academic, cancer center, hospital, or health system owned, physician owned, or federal government like a VA hospital, or perhaps just research? So if you could just kindly answer whichever best identifies for you, that'll be great. Sorry, there's little time delays here. Okay, looks like it's coming now. And we have academic 29%, cancer center 12%, 22% hospital system, 28% described as just research, which is interesting. Okay, let's go to the next one. Number 4, if you are a practicing clinician, how many patients with myeloma do you provide care for in a typical month? So this is per month, how many? 5 to 10, 11 to 15, 15 to 20, or 20 plus. All right. So this, I believe, is the last polling question. Okay. Coming soon. There we go. All right. So 34% see at least 20. So some pretty active myeloma practitioners here. A smaller percentage just seeing a few patients. So very, very helpful to be aware of this clinical practice. All right, so let's move forward just to summarize what is the agenda for today's program. First of all, early treatment for high-risk smoldering myeloma, going for a cure. This will be presented by Shaji Kumar. Individualized approaches to frontline treatment selection by Philippe Moreau. Managing the patient with relapsed disease after at least one line of therapy, Jesús San-Miguel. Understanding the different anti-BCMA therapies, Tom Martin. Future directions and key studies from ASH 2020 by Vincent Rajkumar. And then finally, as we've been doing in these recent years, there will be a presentation of proposed 2021 treatment algorithms, and those will be presented both by Vincent and then for outside the US by Philippe Moreau. So if we can move forward here now, let's move to our first topic, which will be early treatment for high-risk smoldering myeloma, going for a cure, to be presented by Shaji Kumar. So please welcome Shaji. I'll relinquish control of the slides to you, Shaji.
Hey, thank you, Brian. Good morning, good afternoon, good evening, wherever you are. It's unfortunate we could not all be in the same room in sunny San Diego, but this program is going to be no less exciting than every year, maybe even more so, with all the new advances in the treatment of myeloma. So what I'm going to try and talk about today is the approach to high-risk smoldering multiple myeloma and how the paradigm has shifted over the past few years. These are my disclosures. Now we will start off with a patient scenario here. So we have a 56-year-old woman who was noted to have elevated total protein during routine evaluation and underwent some additional workup. Hemoglobin was normal at 13.2. As you can see here, patient had normal serum calcium, creatinine, normal LDH, and a beta-2 microglobulin of 3.7. The serum protein electrophoresis showed a 2.3 gram M spike, which is an IgG kappa. Serum free light chain assay showed kappa of 40 milligram per deciliter or 400 milligrams per liter, lambda 1.2, and a ratio of involved to uninvolved light chain of 33. Bone marrow biopsy had 40% plasma cells. FISH showed a translocation for 14. Whole body low dose CT scan was negative for any lytic lesions, and MRI spine showed some heterogeneity with no discrete lesions. So let's jump into the question here. What would you do if you saw this patient in your current practice? Would you continue with observation and repeat testing in 6 months? Continue with observation and repeat testing in 2 months? Start treatment with lenalidomide dexamethasone? Start treatment with bortezomib, lenalidomide dexamethasone with a plan for an autologous stem cell transplant after 4 cycles? Enroll in an interventional clinical trial? Or you're uncertain of your choices? Please go ahead and vote on these choices. It's too bad we don't have any music. All right, we should be seeing the results here pretty soon. All right, well, we have quite the spread of the opinion here. Well, that's a good place to start with. So let's take a look at what the 5 of us thought about the choices here. So the slide here shows what each of us would have done. And, you know, the common theme here, what I really want to highlight is the fact that we all wanted to do something for this patient in terms of intervening, whether it's a clinical trial or starting on treatment. And clearly, as we saw with the polling, there's a wide range of opinions about what we should be doing with these patients. So let's just start from where the controversy regarding the smoldering myeloma has come about. So smoldering myeloma as a clinical condition was initially described almost 40 years ago by Professors Kyle and Gripe. Now, we all are very familiar when we have a patient with active myeloma in front of us with endogen damage, whether it be bone disease or renal failure. But what doctors Kyle and Gripe described at that time were 6 patients who otherwise would have fulfilled the diagnostic criteria for myeloma at that time, but had a very indolent or non-progressive course. So over the past 40 years, what we have been trying to figure out is what to do with patients with this particular stage in their course of disease. Now, sometimes it seems very simple, right? If someone has a condition that is likely to become myeloma, should we not be doing something about it? So the question is, why have we not been treating smoldering myeloma up until now? The answers had been various. It's because patients are asymptomatic. We did not know who was going to get myeloma. The treatments in the past have been toxic and have limited efficacy. And most importantly, there had not been any evidence to suggest that it improves survival. Now, this has all changed in the past few years, over the past decade or two. We all know that even though the patients are asymptomatic, their first symptom can be quite catastrophic. They could present to you with acute renal failure or a cord compression with paraplegia. In the past, we were not sure who would get myeloma, but we have developed better risk stratification systems. So we have better ability to predict who is going to get myeloma. And the treatments have clearly improved, as you all know, who treat patients with myeloma. And we have now results of phase 3 trials, which tells us that the survival is indeed improved in these patients. So let's first take a look at how can we best define who is at the highest risk of developing active myeloma. Now, in the past, a few years ago, 2014, the myeloma diagnostic criteria was refined to include patients who have not yet developed the end organ damage, but had what we call myeloma defining events, which are a biochemical in nature, for example, with a free light chain ratio that's more than 100, or a bone marrow plasma cell percentage that's 60 or more, or a MRI scan that showed lesions which are non-lytic. So we are already kind of crossed that red line in terms of treating somebody who does not have symptoms, but just based on the ability to predict onset of myeloma at a high risk, 80% at 2 years. Now we wanted to redefine how the risk stratification smoldering myeloma should be restructured, given that those ultra high risk group of patients are now being treated as myeloma. So in a large study by the International Myeloma Working Group, almost 2,000 patients, we redefined the risk criteria, again, using the same characteristics, which are the serum M spike level, the free light chain ratio, and the bone marrow plasma cell percentage, but using a different cutoff that is easy to remember, 2 grams of M spike, FLC ratio of 20, or bone marrow plasma cell percentage of 20. Now, if patients had 2 or more of these risk factors, then their risk of progression to active myeloma was almost 46% in the next 2 years, suggesting that half of those patients were going to get myeloma. And these patients, hence, would be ideal patients to be considered as high risk and potentially be targeted for intervention. Now, we know that these scoring system is pretty simple to use, but does not give the granularity that you might need for the patient in front of you. So we also use the same characteristics to form a scoring system, which allows us to give a better sense of the risk for the individual patient in front of you. As you can see in this slide, we also incorporated the FISH abnormality into the risk scoring system. And in fact, when you have a risk score of 12 or more than 12, your risk of getting active myeloma in the next 2 years is almost 72%. Not quite the 80% we use for defining active myeloma, but getting pretty close, suggesting that we can individualize the risk stratification for these patients. So then the next question is there any proof that early intervention is actually going to change the outcome for these patients? These are results of the phase 3 Spanish Curadex trial that randomized patients with high-risk smoldering myeloma to either lenalidomide, dexamethasone, or observation. As you can see on the left-hand side, with almost 11 years of follow-up, the progression-free survival or the time to progression was significantly better with lenalidomide, dexamethasone compared to observation. And most importantly for this group of patients, the overall survival was significantly better. Now, keep in mind this hazard ratio of 0.27 from this trial, because we'll come to that in a second. One of the criticisms for this trial was that this trial did not use advanced imaging. So there might be a significant number of patients in this trial who may have had active myeloma, but were called as high-risk smoldering. Now, the other concern that has always been brought up is that if you treat somebody early with a drug like lenalidomide and dexamethasone, these patients are going to be highly refractory at the time of relapse, and your subsequent treatments might not work. And Dr. Matthews presented data at EHA this year showing with this 11-year follow-up, patients who are randomized to the lenalidomide dexamethasone arm, when they actually progressed and received myeloma therapy, their outcomes were in no way compromised by that early intervention approach. Now, one could argue that we only cannot depend on a single trial to make choices for our patients. But wait, we have one more phase 3 trial. We have the E3AO6 trial, which is the ECOG trial that randomized patients with high-risk smoldering myeloma to lenalidomide or observation. And we find a similar benefit in terms of PFS. Again, a hazard ratio 0.28 in terms of improvement in the progression-free survival in these patients. Now, one could argue that when you look at the observation arm, the 2-year risk of progression is only 0.76 and not the 50% that we talked about for high-risk smoldering. However, when you look at that same high-risk group that we just talked about using the new IMWG criteria within the E3IO6 trial, what stood out was that this is the group of patients who had all the benefit that we see in this study, suggesting 2 things. 1, the risk stratification system is quite valid. And 2, those patients see a similar amount of benefit as we have seen in other trials as well. Clearly, these trials don't answer all the questions that we have. We have more questions than answers at this point. If we treat, should we be treating these patients like myeloma, or should it be a low intensity therapy to delay progression? Or even importantly, a more provocative question, should we be treating them aggressively at this early stage to potentially cure the disease? And if that is indeed our goal, what is a good surrogate for cure? Is it minimal residual disease negativity? Is it a sustained minimal residual disease negativity? And when do we stop treatment? We cannot continue to treat patients with smoldering myeloma indefinitely. We need to have a limited duration of therapy. So we have several important trials that are asking this question. The EAA 173, the DETER-SMM trial, is a large phase 3 trial that is being done in ECOG right now that randomizes patients to a myeloma type therapy like the daratumumab, lenalidomide, dexamethasone, or a Curadex type treatment with lenalidomide, dexamethasone, but given only for 2 years. And so this is an important trial that it's available to patients all over the United States, and I would strongly encourage you to consider enrolling in this trial. Another trial that is being done by the Spanish group is the GEM-CSAR trial, where patients with high-risk smoldering myeloma are getting 6 cycles of carfilzomib, lenalidomide, dexamethasone, a single transplant, 2 cycles of consolidation, followed by maintenance for a defined duration of therapy. So the entire package of treatment is for 3 years. I want to point out 2 things. One, when you look at the addition of the stem cell transplant, you can see that you're improving the depth of response. The MRD negativity almost doubled between the end of injection therapy and transplant. And 2, patients with high risk or ultra high risk disease have similar response to the treatment. The second important part of the results that we know so far is that each step of this treatment does improve the depth of response over time. As you can see here, the MRD negativity went from 1/3 to almost 2/3 by the time you completed the consolidation therapy. And this was maintained during the maintenance phase. Now, obviously, the conventional endpoints like PFS are fairly short in terms of follow-up. We only have 3-month follow-up. But the PFS is excellent at 92%, and the overall survival, nearly all these patients are alive. But clearly, ongoing trials are looking at the concept of using sustained MRD negativity as an endpoint to define potential cure in these patients. We are doing another trial called the ASCENT trial, where patients are getting a 4-drug induction therapy. As you will hear from the subsequent presentations, the quadruplets are increasingly being used in newly diagnosed myeloma. So patients are getting carfilzomib, lenalidomide, daratumumab, and dexamethasone, induction, consolidation, intensification, a year of therapy, and then a year of maintenance. And the data so far looks quite promising in terms of the depth of response. So that brings us to the point of what we should be doing today for patients with smoldering myeloma. The first step is to make sure we have the correct diagnosis, and that involves the use of advanced imaging, and then identification of high-risk smoldering myeloma by the current criteria we just talked about. And this criteria is going to evolve over time as genomics get involved or incorporated into these risk stratification systems. We certainly need to consider them for some form of intervention based on the phase 3 trials, whether it be lenalidomide, dexamethasone as in the previous trials or the new trials that are exploring new options. If no treatment is instituted, these patients need to be observed extremely closely. Patients with standard risk myeloma, we should follow them every 3 months. And if you start seeing an evolving disease characteristics, we should certainly consider them for clinical trials or early intervention. Still unanswered questions, what if you have a patient with smoldering myeloma who have multiple high-risk features? Should we be treating them as myeloma? That is an area of increasing research, especially the incorporation of genomic high-risk characteristics, and we will have more information in the coming years. So I'll stop there and move on to our patient case again and see if any of you have changed your opinion so far. So again, just to refresh your memory, this is a 56-year-old woman who comes to you with elevated total protein, normal hemoglobin, normal calcium, normal creatinine, LDH is normal, beta-2 microglobulin of 3.7, IgG kappa M spike of 2.3 gram, an involved to uninvolved free light chain ratio of 33, 40% plasma cells in the bone marrow, and a FISH with translocation for 14. No lytic lesions with advanced imaging, MRI looks normal. Let's go ahead and vote again. The choices that you have is be to continue the observation and repeat the testing in 6 months, continue observation and repeat testing in 2 months, start treatment with lenalidomide dexamethasone, start treatment with bortezomib lenalidomide dexamethasone with plans of a stem cell transplant after 4 cycles, or enroll in a clinical trial, or you're still uncertain about what you want to do for this patient. All right, please go ahead and make your choice. I see we have almost 800 people logged in. That's wonderful.
Mm-hmm.
All right. Okay, that is excellent. I think we have got the runoff votes here for 50% for enrolling in a clinical trial. Excellent. All right, we'll move on to the panel discussion, and I'll hand it over to you, Brian.
Well, thank you, Shaji, for that excellent presentation. And we already have a number of questions in the chat box, but perhaps I'll turn to our panel and see if they have any initial comments. One thing, well, maybe just for you, Shaji, first, is that you didn't emphasize some of the key points in the case as it relates to the scoring, the high-risk scoring. Would you perhaps like to comment on that first?
Absolutely. And I think I was hoping to keep it for the panel discussions.
Okay.
I think it's, the 20-20 system is very easy to implement and good for clinical trials and uniformly implemented. But for the patient in front of us, I think the decision need to be driven by what is that individual patient's risk. So for example, the patient that we had here, a free light chain ratio of 33 gives you a score of 3, an M spike of 2.3 gives you a score of another 3, and with a 40% plasma cells, that is a 5. So now we have 11, and a FISH abnormality of 414 translocation, that is a 13. So here we are looking at a patient who is in this purple line on the top with almost a 73% risk of progression to active myeloma. So clearly this is something, from a prognostic standpoint and your own decision-making process in that conversation with the patient. Do we intervene with what we already know from the clinical trials, or you choose the clinical trial that gives an option for treating like an active myeloma? I think those kind of decision-making process can be guided better by the granularity that this risk scoring system provides. And in fact, this tool will be available on the website that you can actually log into and put in the values for the patient, and it will tell you what this risk assessment system is going to be. And Brian can probably provide some additional details on that as well.
Exactly. So, but for this type of a patient with a score in excess of 12, probably in a clinical trial, you probably would not want to have a placebo arm, maybe a choice between 2 levels of therapy, perhaps, right?
That is quite true. And I think most of the clinical trials right now, the randomized ones, are looking at intervention in both arms. And we are trying to answer the question of myeloma therapy versus progression or versus less intense therapy. So you're absolutely right. I think in a patient like this, maybe you want to think about more of a single arm trial where you already know what therapy they're going to get, or treatment outside the clinical trial would be appropriate as well.
Right. So other panel members, Vincent, Jesus, Tom, Philippe,
Vincent.
Brian, I completely agree with Shaji and what he just presented. This is the type of patient where you need to do something. And actually the threshold at which you say you need to do something starts when you have a 50-50 risk of progression.
Yeah.
In those patients, the Spanish trial and the ECOG trial shows that any kind of intervention, even a mild one like lenalidomide or Lendex, will reduce the risk of end organ damage by 90%. So sitting and waiting and watching them is to me not a right option for the patient with high risk smoldering myeloma. And the only difference is, what do you do? clearly the clinical trial will be the best choice. And thank God right now we have many, many trials. And so I agree with the entire panel that clinical trials would be the best choice. At a minimum, I would do Lendex. And then in this particular patient, given multiple high-risk factors approaching the level of myeloma, I would find an excuse to treat the patient as myeloma. So what Dr. San-Miguel mentioned for this patient as VRD, if a trial was not available, would be just absolutely fine with me. But the message that the audience needs to take home, and I think they did because 96% said they will do either a trial or Lendex or VRD, is that when you have 50-50 risk of progression, and that happens when you have got any two of the three, 2-20-20, 2 grams M spike, 20 for light chain ratio, and 20 for the bone marrow plasma cells. If you have more than 2 of those factors, 2 or more, then you reach the 50-50 threshold. Don't worry about being perfect. No one can predict exactly who will and who will not progress. But if we follow these rules, you will be more often right than wrong.
Absolutely. Yeah. So Jesus, your thoughts?
I would echo what Shaji and Vincent has already mentioned. And for those that feel uncomfortable by starting treatment because they are more conservative, my recommendation in this case for those people is that they should be clearly sure that they don't have an accumulation of risk factors. Before making the decision that I don't want to treat, you must be sure that you have not an accumulation. In this case, you have 40% plasma cell. The free light chain ratio is almost 40. I mean, you have also cytogenetic abnormalities, and the MRI was not normal. Therefore, before you say no, be sure that you are right to make this advice for the patient.
Right. So actually, we have a question in the chat box that relates to that. In this case, the whole body low dose CT was normal, and so the question is, would you do other imaging to be sure in a patient like this where the plasma cell percentage is fairly high?
I think so. I think the important thing is to figure out what is the maximum number of risk factors a given patient has. So I think in somebody where the whole body low dose CT scan is negative, I certainly would do an MRI like what was done for this given patient, because you want to make sure, you want to exclude the possibility of any high risk factors being missed out.
Right, absolutely. Okay, any other thoughts or comments? We have another question here, and maybe Jesus, you can answer this one. For the patients who progress after the lenalidomide in the Caesar trial, what would be recommended?
Okay, I should mention that in the Caesar trial, the lenalidomide Dex, the treatment was for 2 years. Then when the patient relapsed, were off of treatment, and this probably explained why the outcome of these patients in the experimental arm was so good. In fact, it was better, the outcome of these patients that have received a previous treatment as compared to the outcome of patients that did not receive treatment until they progress. Therefore, I think this is another message that in these patients, when you achieve a very good profound response, you can be treated with a treatment-free interval really prolonged. Here was 9 years median progression-free survival.
Yeah.
Right.
And Brian, if I may, there are 2 criticisms that people come up with, and I just want to make sure people are aware what the drawbacks of those criticisms are. Absolutely. Number 1 is what Dr. San-Miguel just mentioned. Oh, if you just gave them lenalidomide and they accumulated risk factors and then they didn't do well. Well, we have 2 trials that actually tested that hypothesis and found that therapy with lenalidomide did nothing like that. It actually prolonged overall survival in the Spanish trial and led to major reduction in end organ damage in the ECOG trial. So that concern, if it's there theoretical, has already been debunked by the 2 randomized trials. The second concern people have is, oh, the risk factors don't overlap. I mean, the Spanish have some risk factors that are different than the Mayo risk factors, yeah. And that's different than the 20-20 risk factors. It really doesn't matter. Whatever method you use to find out a patient has a 50-50 risk, that's enough. You don't need to have each method to identify the same patients. They complement each other. You use all the factors that you can possibly do to ascertain whether your patient is really high risk or not. And now the pendulum has swung. It's imperative you be sure the patient is not high risk rather than the other way around.
Absolutely.
I think this point that Vincent has raised is very important, because some people say, okay, but if I use one classification and the other, they don't match. But this is good that they don't match. If you have, for instance, a patient with 17p deletion, but without extramedullary disease, this is a bad case. If you have a patient that has not 17p, but has extramedullary disease, it's a bad risk. I mean, in other words, these are complementary and allows you. And another point that I want also to raise is based on the 2020 and also the scoring system, particularly with the scoring system, if you apply individually to the patient, you can also identify the low risk patients, patients that will not need treatment. Therefore,
Absolutely.
I think this classification has two advantages. Because one is the simplicity, and the other is that discriminate between the high and the very low risk.
Right, right. Maybe we can just show that slide again just for a moment. Yes. So what Jesus is talking about is that bottom red line where you can see the risk is very low out to 60 months. So that this is very, very important to identify this type of patient who is at low risk for a long time.
So, Brian, another question in the chat box I thought was very interesting was, should we be happy with just a partial response in patients with smoldering myeloma? And I think that's an important question, because I think, increasingly what we're saying is we want to give an intervention that will reduce the risk of progression. I don't think we are at a point where we are saying that if somebody with smoldering myeloma gets an intervention and they only get a partial response, that we should change therapy. I do not think we are at that point yet. I think we should say this is our 2 years of treatment we're going to give for this patient with high-risk smoldering myeloma. Whatever we get, we stop there and watch what's going to happen with the disease. Because we all have patients in our practice who might get a partial response after treatment of myeloma and then go 5 years without progression. So we certainly don't want to be jumping into that conclusion at this point.
Yeah, very, very important point. Just to get another couple of questions here. A question is about why not try DARA? I mean, I think that obviously in the ECOG trial, that's actually what you're evaluating, right? So,
so can I mention something too, Brian?
Yes, yes, Tom, go ahead.
So in this case, because Shaji presented a person that's really high risk. And so I think we're all nervous about this patient. And literally, if we don't do anything, in 6 months, they very likely have a 50% chance of having end organ disease and being treated as myeloma, multiple myeloma, pulling out whatever drugs you would do for a high risk with those cytogenetics myeloma patient. So I think you have to think about that and balance that. So if you treat them 3 or 6 months earlier, I think you have to think about which therapy you're using. You know, 3 or 6 months earlier doesn't mean you can use less, in my mind, less therapy. You should probably choose what your best therapy is at that point in time.
Absolutely.
Totally.
I'm very supportive of that strategy and philosophy. Yeah. Okay. So very good. So I think that we do have a few more things on the chat box, but I think that we are running a little bit over now, but this was a good discussion, but I think we should move on. And this actually, Tom, is a good segue about individualized approaches to frontline treatment, which is our next topic. So without further ado, I'd like to turn control of the slides over to Philippe Moreau, who will be presenting this frontline treatment selection topic. So Philippe.
Thank you, Brian, and good morning, good afternoon to all of you. We have more than 800 people logged in, so that's really fantastic to have this very good discussion. So I would like to discuss with you the frontline treatment of patients with multiple myeloma. And let's move immediately to our patient case. 73-year-old male with bone pain, with an hemoglobin level of 10.2, with an M spike of 4.2, 30% of plasma cells on bone marrow aspirate. The FISH is showing a translocation 11-14, and on the low dose whole body CT, we have diffuse bone lesions. The beta atomic level is normal, 2.5. LDH is below normal, so we have a symptomatic multiple myeloma, ISS1, revised ISS1 as well. So this question for you, in your current clinical practice, what would you recommend for this patient? You have here 7 choices. 73-year-old male, symptomatic myeloma, ISS1, revised ISS. So please go ahead and vote. Definitely we need some music.
For sure, yes. There's also a slight time delay, so we absolutely, maybe by later in the program, we can find some music.
Yep.
I would show some music.
Okay.
Okay, good. So just waiting for your answers. Oh yeah, good, great. So very, very interesting. VRD times 8 followed by Lendex. We have also a DRD, Lendex daratumumab until progression, or for more than 1/3 of you, VRD times 4 followed by autologous stem cell transplantation. So you see very, very different choices. That's very interesting to discuss about this, this case. So what are our expert recommendations? So let's look. Brian, DRD, Shaji, DRD until progression. That was also my choice. Thomas is proposing VRD and stem cell transplantation. And Vincent, VRD times 8 followed by Lendex until PD. And Jesús, DRD until PD or VMP DARA with bortezomib maintenance. So very interesting choices. As you can see, we have very different opinions. So what evidence-based we have based on phase 3 studies for elderly patients not eligible for autologous stem cell transplantation. We have the VISTA study published quite a long time ago now in the VMP arm, the median PFS 24 months, median OS 56 months. We also have the first study evaluating Lendex continuously until progression versus MPT, and Lendex was associated with a median PFS of 26 months, median OS of 5 years. And Brian and his colleagues did publish the results of the SWOG study comparing Lendex until progression versus VRD, 8 cycles followed by Lendex until PD. We also have VRD recently evaluated into this very important study, the Endurance study, comparing VRD versus KRD, published also recently and reported at ASCO. And you see that the progression-free survival was identical when comparing VRD and KRD, suggesting that VRD followed by Len maintenance should be the standard of care. This study did enroll not only young patients, but also elderly patients. And I put here on this slide the results of VRD into the SWOG, VRD into Endurance, and you have a mixed patient population of both elderly and young patients. But for elderly patients above the age of 65, you see the median PFS into the SWOG study, 34 months, and into Endurance, the median PFS of more than 3 years for patients older than 70 years of age. So definitely VRD seems to be superior to Lendex until progression. And the use of monoclonal antibodies with the Alcyone study, VMP versus VMP daratumumab, you see a huge impact of the addition of DARA, not only in combination with VMP, but also DARA was proposed as maintenance after VMP DARA. And the benefit was very important, the hazard ratio 0.4. And I put here on this slide the median PFS into Alcyone of roughly 3 years. And we have also an overall survival benefit with a quadruplet combination, VMP daratumumab. This is the first study showing an OS benefit with daratumumab. But let's move to DRD and the MAIA study. MAIA, to my opinion, is an outstanding study that did compare prospectively Lendex versus Lendex plus daratumumab, and the DRD arm, more than 350 patients were randomized. The median PFS, 30-month PFS, 71%. We don't have yet overall survival data, but looking at the update analysis that will be presented during this meeting by Shaji with a 4-year follow-up, you see the outstanding results of DRD. Well, we can say that the benefit and the hazard ratio of 0.54 is not related to a poor control arm, because the Lendex arm of MAIA is performing very well. And you see the median PFS is in the Lendex arm 34 months, so outstanding results of Lendex. But if you are adding daratumumab on top of Lendex, you see the results that, to my opinion, the best ever reported. And we can anticipate, based on the hazard ratio, to have a median PFS that is not yet reached, that will be something like 55 or more, 55 months. That's currently what we are achieving with autologous stem cell transplantation in young patients. Thinking that into MAIA, the median age was 73 years. So definitely outstanding results. And to summarize these recent trials, you see in blue on the left-hand side of the slide, the VMP data, VMP plus daratumumab based on Alcyone. In red, you have the Lendex arms of different phase 3 studies, and the best one with MAIA. And on the right-hand side of the slide, the VRD regimen and the DRD with a median PFS that will be roughly 55 months, as I mentioned previously. So what is also important to note is that when you are looking at the number of lines that the patients are able to receive in the real life, and this is a picture from the Australian data, you see that very few patients are able to receive 2 or 3 lines of treatment when they are above the age of 70 years in the routine, in the real life. So the message is that you have to give the best therapy upfront when discussing the treatment of elderly patients. And obviously, we know that we have to adapt the treatment according to frailty, and we have different scales looking at frailty. This is the one of the most recent example from the first study showing that the ECOG scale is very, very important to try to adapt our strategy. We can also adapt the treatment, and Vincent did propose for this specific patient VRD, but we can use this VRD light regimen. That's only a phase 2 study, but very good results. If you are reducing the dose of lead, if you are using the weekly bortezomib instead of bortezomib proposed twice weekly, and with a consolidation and maintenance with lenalidomide, you can also achieve very good results. So for young patients now that are eligible for autologous stem cell transplantation, what are the guidelines? Many of us are proposing frontline stem cell transplantation with a triplet induction, the single stem cell transplantation prepared by ML200, and len maintenance until progression that is approved. This is also the choice in many US centers. You see here the NCCN guidelines, the most recent version of these guidelines showing that autologous stem cell transplantation is the preferred choice, category 1 following induction. So this is what we are proposing for young patients in many countries: induction, stem cell transplantation prepared by ML200, and maintenance. What about induction? VRD is probably one of the most effective regimen, and this recent paper from the Spanish group did show that with 6 VRD cycles before autologous stem cell transplantation, we can reach very good responses at a VGPR rate of almost 70%. And after 4 to 6 cycles, we are still increasing the response rate, suggesting that we can propose up to 6 cycles before autologous stem cell transplantation. But an important possibility is also to use a monoclonal antibody, and into the Cassiope study, we did compare prospectively both before and after stem cell transplantation, VTD versus VTD plus daratumumab. And definitely when looking at the results of this study, the responses are deepening over time after induction, after stem cell transplantation, after consolidation. But the best responses are achieved with daratumumab with the quadruplet combination. And we did evaluate on more than 1,000 patients systematically minimal residual disease, MRD negativity before maintenance. And you can see that with daratumumab, with a quadruplet combination, we are reaching MRD negativity in 63% of the patients, 10 to the minus 5, versus 43% with VTD alone. And this depth of response, the quality of the response with the quadruplet is translating into a progression-free survival benefit. And you see the PFS from first randomization into the Cassiope study, the hazard ratio of 0.47, and outstanding results, the best ever reported in a phase 3 study with DARA VTD. Interestingly, when looking at PFS by MRD status, you can see that MRD negative patients are performing very well, and the best results are also achieved with the quadruplet combination. Recently, why not switching from VTD to VRD plus daratumumab? And our colleagues from US reported the results of the Griffin study. That's a phase 2 study on 200 patients, VRD, both before and after stem cell transplantation versus VRD plus daratumumab. And definitely same picture. We have very, very high responses with the quadruplet combination, the stringent CR rate, the MRD negativity rates are much higher before maintenance in the quadruplet combination. And these are the results of MRD negativity, regardless of response. You see that in the DARA VRD arm, before maintenance, 44% of the patients are reaching MRD negativity. And outstanding PFS and OS data, the follow-up is still short. The study will be updated during the meeting, so please go and see the poster on the Griffin update. But nevertheless, impressive results also achieved in the VRD arm of the study. So why using tandem stem cell transplantation? We have interesting data recently reported by the European EMN Consortium. In the intensive arm of the EMN02 study, there was a prospective comparison of single versus tandem stem cell transplantation. And you see that tandem is improving not only PFS, but more importantly, progression-free survival, PFS, but more importantly, overall survival, but especially for those patients with a high-risk disease. And Michele Cavo, again, will update this important study and during the meeting. And in many centers, especially in Europe, we are proposing tandem stem cell transplantation for patients with high-risk disease. What about maintenance that is proposed systematically for following high-dose treatment? We know that standard of care is lenalidomide that is associated with an overall survival improvement based on this meta-analysis on 1,200 patients. The benefit in terms of OS is more than 2 years with len maintenance. So definitely we should use at least lenalidomide, but we know that we have also other trials showing that, for example, ixazomib may improve progression-free survival. The benefit is marginal, to my opinion, with ixa versus placebo, but potentially in the future, we will combine len plus ixazomib. And this is currently the Spanish study looking after stem cell transplantation at len maintenance in a randomized fashion versus len plus ixazomib. And definitely we are awaiting for the results of this study. Into Cassiope, we are also looking at daratumumab maintenance in a randomized fashion. So definitely the landscape will change for young patients eligible for stem cell transplantation, and potentially the guidelines we'll propose a quadruplet induction, VTD, CD38 antibodies, or VRD plus daratumumab, for example, single or tandem stem cell transplantation for high-risk patients, and regarding maintenance, len plus either ixazomib or len plus CD38 in the future. Now, let's return to our patient case, and you are going to vote again. 73-year-old male with a symptomatic myeloma, ISS1, revised ISS1, and I don't know if you're going to change your mind, but these were the proposals. So please go ahead and vote again.
All right. Still a little delay and no music yet.
Yes, it will be interesting to see if people are changing their mind, you know, because yes, a lot of stem cell transplantation, a lot of VRD. So yeah, let's see.
Yeah, yeah. Quite
Vincent, you will be challenged on this topic. Vincent.
Yes, yes. So I don't know if this one we can show the difference, if we can show the two charts, if it seems interesting. Yes. Okay.
So definitely DRD until progression is now the first choice. We have less stem cell transplantation. It was more than 1/3. Now that's 25%. And VRD that was proposed from a significant number of people from the audience is now reduced. So interesting to see the changes. So Brian, it's up to you now.
Yeah, so I think that was quite interesting, but 45% supporting DRD. I think that there's no doubt, as you mentioned, these data are quite impressive, even although we don't have overall survival
Definitely.
Yet. Yeah. I think that there's quite a diversity of questions in the chat box. I don't know that we'll be able to get to them all. It's probably worth commenting that there is a plan to do podcasts. If we have a lot of questions afterwards, we will do some podcasts to try to pick up some of those questions. So any comments from our panel? Shaji, look like you might want to say something. I'm not sure.
Sure. Yeah. No, I think the main question I think we are going to be facing over the next few years is the quadruplet versus triplet question for the newly diagnosed patient. And obviously, these are all expensive drugs, and we really need to figure out two things. One, do everybody need quadruplets, or can some patients get equivalent results with just triplets? And second is, if you're going to use quadruplet, how can we make it cost effective? And the only way I can see that happening is if we limit the duration of therapy to a defined time. So obviously, I mean, there are clinical trials ongoing, and I think we really, before incorporating the quadruplets into our routine practice, I think we need to wait for a little bit more mature data from the phase 3 trials if you're going to use it for all patients.
Right. So,
and if I may ask a question to Vincent. Vince, you are proposing VRD for this specific patient, 73 years. Looking at the difference in terms of PFS, and as clearly stated by Brian, with DRD, with Maya, we don't have yet overall survival data. But the difference in terms of PFS is very, very important. That's something like 36 months with VRD. We can anticipate to have 20-month difference with something like 55, 56 month median PFS with DRD. Knowing that, as I mentioned, for elderly patients, you should propose the best upfront. Knowing that we will have Dara subQ available, I know that we have drug access. The cost is not zero for sure. But don't you think that we should propose the best treatment upfront for elderly patients?
Philippe, couple of points. I think we shouldn't confuse what happens when you give a triplet indefinitely versus what happens when you give a triplet for 6 months and then a single agent, which is the VRD data is basically VRD for 6 months and then patients get just Lendex.
Yeah.
So you get 34 months. But if you give a triplet for the whole period of time, of course, the PFS will be longer. If you take the Pollux trial at first relapse, if you just use DRD at the end of your 4 years, if you give VRD and you get 3-4 years, and then you give the DRD, in the Pollux trial, the PFS was 44 months. So it's not like by just not giving the DRD front, you're going to have an inferior overall survival. I think it is very important for experts to be very clear that we have no clue if you did a randomized trial of VRD versus DRD, at the end of the day, who will live longer? They could be the same. Yep. One could be worse, one could be other. And to assert that we know the difference just because we gave 3 drugs forever and therefore people live with better PFS is not a very right way of interpreting it. Mm-hmm. Secondly, you have to understand what is realistic in terms of cost. Mm-hmm. Daratumumab costs a lot. If you're going to give it month after month after month for 4 years or 5 years or 7 years, mm-hmm. you need proof that doing so will actually make people live longer. Until then, I feel like you cannot be so sure. Now, that's why in my algorithm, I would say you could do either VRD or DRD, and I won't be so cocksure that you have to do DRD because I don't know that that's actually going to make people live longer.
Agree, Vincent. That's just to open the discussion. In the algorithm, I will propose the same, DRD or VRD. But definitely, we have to look as well at the tolerance of the treatment, what we can use as salvage regimen. That's a very important point. You mentioned VRD followed by LEN, and you are discussing DRD at the time of the first relapse. But those patients are LEN refractory when you are using VRD followed by LEN. And I think that you cannot use the DRD combination for LEN refractory patients. That's also something very difficult to think about, the sequence and also the PFS too. That is also very important to consider.
So just a lot of the VRD data actually, Philippe, is not patients relapsing on LEN maintenance. They usually take it only for 2 years and then they stop.
You're
most of the studies, whether you take the SWOG trial or the other ones. Most of them are on 5 milligrams of LEN. So it's not like they are not going to. They are pretty similar to the Pollux population. And if you're really worried, you could use DPD or DVD. You are not going to deprive people of getting daratumumab.
Yeah. Brian?
Yes.
Following the question of having a patient that relapse under lenalidomide, that we know that we are going to discuss later on today.
Yes.
This is a challenge, the patient is refractory to lenalidomide. And for this reason, I choose DARA-RD as the first option because I think it's probably the best. But I also suggest the Alcyon study DARA-VMP. And the reason is because if you don't stop bortezomib after 9 cycles, as Vincent has already mentioned, and you give the patient the maintenance with DARA and bortezomib every 15 days, I'm sure the PFS is not going to be 35 months. It's going to be much higher. And I think this was a mistake in the design of this study, that the patients would benefit and they will be LEN-free. Nevertheless, I would say that I want to use in the elderly patient the best possible treatment up front, because as Philippe has beautifully shown in the slide from Andrew Spencer, there is a minority of patients that are able to receive 2 lines of therapy. I think this is a consideration that is important to keep here in mind.
Oh, good point. So I'm just seeing there are a lot of diversity of questions here. I'm not sure what. Talking about that, it says here from Dr. Abdallah, in the Cassiopeia trial, the VTD arm did not receive maintenance therapy. Is that true?
In fact, in the Cassiopeia study, we have a second randomization between DARA and no DARA. So half of the patients who did receive VTD upfront did not receive any maintenance, and half of the patients with VTD received DARA maintenance. In fact, when we designed Cassiopeia, lenalidomide was not approved and reimbursed in Europe. So that's why we did not implement systematically LEN maintenance. Probably, for sure, now, if I have to do the study again, I will use LEN maintenance and try to compare LEN versus LEN-DARA. But at the time of the first patient in, LEN was not available and reimbursed. in Europe.
Right. There are several questions that relate to the impact of high risk, you know, in the comparison of VRD and DRD, and also in that category, what would be the role of tandem transplant? So I don't know if you want to comment on those couple of points.
Well, I think that the high risk disease, we still have this very difficult to treat subgroup of patients. We showed previously, and we are going to publish those data on Tucasiope, for example. Patients are really benefiting from DARA. But if you are comparing high risk versus standard risk in the VTD DARA arm of the study, the high risk group is performing, the PFS is inferior, definitely, as compared with standard risk. The same is true for DRD for elderly, for example. If you are looking at high risk cytogenetics, the hazard ratio is not that good with DRD as well. So we are still have this issue of high risk cytogenetics. And I know that in the SWOG study, Brian, that you did publish, unfortunately, we didn't have a lot of data on cytogenetics, but maybe Shaji and Vincent, you could speak about endurance and VRD versus KRD for high risk.
So, you know, for the endurance by design, we did not have the high-risk patients with the exception of the 414 transfer
414,
patient.
you have 414.
So the 414 patients were included in that study, and they also had very similar PFS outcomes for KRD versus VRD within that subgroup of 414 patients. We also had the 1Q amplified patients in there. We haven't looked at that data. So that would be another aspect that would be explored in the future.
Another question in the chat box here, Philippe, is in light of the STAMINA trial, where there was an impact of continued LEN maintenance to progression, should we be more focused on that?
That's a very important point. You know, the duration, the optimal duration of maintenance is key. We know that, for example, in the meta-analysis published by Dr. McCarthy in the GCO, the median duration of LEN maintenance was 2.4 years. And many patients did stop, either for progressive disease, but also a very high number of patients because of toxicity. We will have, I hope soon, the comparison of the French study with VRD stem cell transplantation and LEN maintenance 1 year versus the US study that used LEN maintenance until progression with the same design. And we will be able to compare 1 year versus LEN until progression. Currently, I think that the optimal duration of LEN potentially should be something like 3 years, because that's potentially the best duration looking at efficacy versus safety. So that's why into the French guidelines, we are recommending either 2 to 3 years of maintenance with LEN, fixed duration. That's also important for a patient to be to have some treatment-free interval after maintenance.
Right, very, very good points. Okay, well, I think that we need to move ahead, but as I say, we will be picking up these questions from the chat box. But thank you so much, Philippe. Excellent presentation and excellent discussion. We'll move forward to our next presentation now. And so very, very pleased to welcome Jesús San-Miguel, who for this year will be talking about how to treat relapsed refractory myeloma in 2020 and moving into 2021 for sure. So Jesús, I turn over the slides to you.
Thank you very much, Brian. I don't know if you are able to see the backup from my face that I'm showing here. We will beat myeloma. And this is the hope for the coming years. Okay, now let's start this as my disclosures with a clinical case number 3. This is a 66-year-old man that was diagnosed with IgA lambda revised ISS3 myeloma. Bone marrow plasma cells was 60%, 414 translocation plus 1Q gain, anemia, the M component was 25 grams per liter, extensive bone disease. He received DARA VTD plus autologous transplant, achieving a stringent complete response, but remained MRD positive. It was planned for maintenance with lenalidomide for 2 years, but unfortunately, after 23 months, this means 18 months from the autologous transplant, the patient relapsed. Therefore, here are the questions. In your current clinical practice, how would you treat this patient? A proteasome inhibitor plus lenalidomide and dexamethasone? PI plus pomalidomide dexamethasone? A CD38 monoclonal antibody plus len-dex or plus pom-dex? Or a CD38 plus proteasome inhibitor and dexamethasone? Or rescue with a treatment followed by a second autologous transplant? Finally, you may be uncertain. Now vote. Okay, do you want to continue with the music or let's see the vote? Okay, really, this reflects how difficult it is to make decisions here because it's really splitted in different options. Almost 1/3 proposed CD38 pomalidomide dexamethasone. Anyway, let's continue with the case. This is what was the proposal from the panel. CD38 plus proteasome inhibitor plus dexamethasone. Brian proposed CD38 plus pomalidomide, and I propose also CD38 plus pomalidomide. Now, let's move to the case. The patient was treated with Dara-VD 8 cycles and achieved a VGPR. But unfortunately, the patient has progressed 3 months later. Then you have here the options. Now you can use a proteasome inhibitor plus pomalidomide and dex, or a CD38 or elotuzumab plus pom-dex, CD38 plus carfilzomib dex, selinexor, in combinations, belantamab, venetoclax, melfuflen, or bispecific antibodies. Now, please vote. Okay, here we have the responses, and I think it's good to see that 26% propose monoclonal antibodies, also a good proportion propose new drugs such as belantamab or selinexor, venetoclax, but still there is a good proportion that is propose the CD38 in different combination or elotuzumab in different combination. Okay, now let me move to my presentation. These are the responses from the panel that most of us are proposing CAR T cells except, or bispecific antibodies, except Vincent that is proposing PI plus pomalidomide and dexamethasone. Probably you have realized how difficult it is nowadays to make decisions about treatment in the relapse setting. And for this reason, the responses were so split, and we need a compass. We need to define individually each patient. What are the disease-related factors at the time of relapse, type of relapse, biochemical, aggressive, cytogenetic risk, patient-related factors, age, is transplant eligible again, comorbidities, frailty. We should also consider the efficacy and toxicity of previous treatment, and finally, further options. What are available in our center for such a patient? But before I discuss about potential options, let me discuss with you 3 specific considerations. First of all, it's important the depth of response in the relapse setting. I think everybody agree that the depth of response, particularly to achieve minimal residual disease, is very important in the upfront setting in the transplant eligible patients. Also, nowadays, it has become evident that it's important, relevant in transplant ineligible patients. And if you look to the curves, the difference is probably higher, or the impact of MRD negativity is even higher in the non-transplant patients. Why this occur? Probably because, as we have already seen from Philippe, the elderly patients have only 3 or 2 lines of therapy. But what about the relapse setting? Does the depth of response MRD influence the outcome? This is a clear evidence that is even more important, particularly in first relapse, because is that at that time the only treatment that some patients will receive, the rescue therapy. Therefore, we should offer our patients the best possible treatment. And this has been already shown in the Paulus and Castor data RD or data VD, that patients that achieve an MRD negative, and particularly a sustained MRD negativity, show a significantly longer progression-free survival, and also nowadays also overall survival. The second consideration that I want to discuss with you is whether or not should we treat biochemical relapses. In this slide, I am comparing in the left part the PFS and overall survival. If you treat at biochemical relapse, in the right part, you have treatment at clinical relapse. And this corresponds to a clinical trial, the Endeavor trial, in which KD has been compared with VD. I don't want you to look for the survival course comparing the 2 arms. I want just to compare, and here I pick up the example with KD, but it's exactly the same with VD. If you treat at the time of biochemical versus clinical relapse, as you can see, the progression-free survival is longer if you treat at biochemical relapse, and the overall survival is significantly longer, independent of the treatment that you are choosing. The third consideration is, can I still go for a second rescue transplant at the time of relapse? I think nowadays with so many drugs, the frequency of second autologous transplant at the time of relapse is decreasing, but still I think there is room for rescue therapy with followed by autologous transplant in case of a late relapse. This means that relapse occurred 3-4 years after the first transplant. In other words, have a prolonged treatment-free interval. And in that particular case, you probably can offer the patient a rescue therapy with a second transplant. And now let me move to the real definition of what treatment to choose. And first, I want to discuss a patient that has received, for instance, induction with VMP, is a not transplant candidate, or a transplant candidate that has received VTD, autologous transplant, and maintenance with lenalidomide just for 1 year or 2 years, and then has a relapse, but not refractory to lenalidomide. In that particular setting, I think everyone will think on Lendex as a rescue therapy. But we know nowadays that triplets are superior to doublets. And here I'm sharing with you 4 randomized trials in which there is the evidence that triplets are better than doublets. First of all, the Paulus, then the Aspire, Eloquent, and Tourmaline trial. And I saw in this table, first, the hazard ratio for each trial in bold letters, then the increment, the increase in progression-free survival, and below you have the progression-free survival for each arm. As you can see, the DARA-RD is the combination that afford the longer progression-free survival, 44 months, followed by KRD, 26 months. In the first case in the Paulus, the increment in progression-free survival is 26 months, is almost 10 months in the Aspire trial, and goes to around 5 months in the Eloquent and Tourmaline trial. But if you are short of resources and you have only Lendex that has become already generic lenalidomide, you can consider the possibility of adding cyclophosphamide, a cheap regime, Lendex plus cyclophosphamide, in case you have no resources. And we should think about this for many of the people that is listening to this session. The second case that I want to discuss with you is a different one. It's a patient that has been treated with Lendex, Dara-Lendex, or Len maintenance after transplant at a 10 milligrams minimum daily. In that particular case, I will consider that the patient is Len refractory. And in that setting, probably the best option is to move to proteasome inhibitors. And here we have the doubt between a doublet based on VD or KD. The Endeavor study is the first one that I am showing, has compared face-to-face KD versus VD. And again, I'm showing the hazard ratio, the increment, the increase in progression-free survival in brackets, and below the median PFS for each of the arms. As you can see, it's double PFS, 9 months difference for KD, VD. In this meeting, the Spanish group is going to show KCD, adding cyclophosphamide. The difference between KCD and KD was not statistically significant, but in the true Len refractory patients, it showed that the addition of cyclophosphamide can be of interest. You can attend this, it's an oral presentation. But again, triplets probably are the best. And you can here have two opportunities to use daratumumab or ixatushimab combined with bortezomib or with carfilzomib. The Castor study has combined Dara VD versus VD, and as you can see, there is a superior progression-free survival, 9 months increase for Dara VD, something similar to the KD. And this is the reason why the Cantor and the CHEMA study has tested Dara KD or ISA KD versus KD, probably thinking that KD can be the control arm for these Len refractory patients. The median progression-free survival has not been reached in neither of these two studies, but looks really very promising, very positive result with hazard ratio 0.6 and 0.5. Nevertheless, I should mention that none of these trials really reflect the real case that I am showing, because as you can see in the bottom part of the slide, only around 30% of the patients included in these studies were truly Len refractory patients. For the Len refractory patients, the true Len refractory patients, the first study that has focused in this population was the Optimist study. And this is a study in which pomalidomide, bortezomib, and dexamethasone has been compared with bortezomib and dex. And as you can see, there is a significant superiority for the experimental arm, POM-VD, and the median progression-free survival in first relapse, instead of 11 months, go to 17 months, and the increase in progression-free survival is around 4 months. And again, if POM is able to rescue Len refractory patients, why not to add a monoclonal antibody? Either isatuximab, the CARIA study, or ilotuzumab, or the eloquent study of daratumumab, the Apollo study. In these 3 studies, there is a clear benefit for the experimental arm. However, the difference versus PD is not so striking. It's just around 5 months. And the median progression-free survival in these studies is around 1 year. In other words, we are facing really refractory patients. And therefore, I think everybody wants to see the results of the Cantor and Ikema study, Dara KD and ISA KD, because in the Len refractory patient, the hazard ratio looks promising, but we have no data really to make such a recommendation nowadays yet. Okay, therefore, if we are facing so refractory patients, this means that we need other drugs. And here are showing some of the new drugs that probably in the future will rescue many of these patients. First, the new cell mods. And we have iberdomide and 92480. Both new cell mods are able to rescue Len refractory patients and even POM refractory patients with a response rate of around 30 to 54%. And nowadays, iberdomide, and in this meeting, there are going to be 2 presentations of iberdomide in combination with daratumumab and bortezomib, in DARA refractory and bortezomib refractory patients with very promising results. Melflufen. Melflufen is a highly lipophilic alkylating agent that we note that the intracellular aminopeptidase that are overexpressed in malignant cells will rapidly cleave melflufen, releasing the hydrophilic active alkylator metabolites. And in vitro studies, it has been shown that it has 54 higher intracellular concentration of alkylated metabolites as compared with equimolar doses of melphalan alone. The response rate in the 2 phase 2 studies that has been already reported is around 30%, with median progression-free survival ranging between 4 and 5 months. And in this meeting, Dr. Osio will report on the combination of melflufen, dex plus DARA, or also plus bortezomib, with a response rate that increased from 30% to 60-70%, and a progression-free survival that increased from 5 months to 11 months, but data is still preliminary. The second drug that I will discuss is selinexor. As you know, exportin is a major nuclear protein for tumor suppressor proteins. And therefore, exportin, we know that is overexpressed in myeloma cells and take out from the cell the suppressor genes that are critical. Therefore, selinexor will be a very valuable drug since it's an oral selective inhibitor of exportin. The first study, selinexor dex, that has been already reported, including over 100 patients, show that a single agent in patients that are refractory to bortezomib, lenalidomide, carfilzomib, pomalidomide, and daratumumab, 26% of the patients respond with a median progression-free survival of 3.7 months. And the Boston study that has been recently published in Lancet shows the results of the combination of selinexor plus bortezomib dexamethasone versus bortezomib dexamethasone. The median progression-free survival goes up from 9 to 13, 14 months with a hazard ratio of 0.7 and a duration of response of around 20 months. In this meeting, also, we are going to have the opportunity to see the results of selinexor plus pomalidomide dexamethasone, the STOMP study, with 58% overall response rate and median progression-free survival of around 1 year. Last but not least, venetoclax. Venetoclax, as you know, is a small molecule, a BCL2 inhibitor that induces cell death in myeloma cells, and is particularly valuable for patients with translocation 11 for 14 and patients with high levels of BCL2. And as you can see in this slide, the impressive benefit in progression-free survival has been observed in these 2 cohorts of patients. And finally, I will just mention that we have now the BCMA targets, and is going to be discussed by Dr. Martin in the next presentation, all the data about, but belantamab is a conjugated, and so already responds a single agent, and he will expand all this information. And I think I will finish with this slide for all of you. I think the progress in myeloma cell biology by identifying new prognostic factor and myeloma subtype, together with the discovery of drugs with singular mechanism of action, will allow you to individualize and to tailor treatment. And I think I will stop here, but before that, let's return to the clinical case. You remember this clinical case, 66-year-old man that has high risk, very high risk, DVT, DARA-VTD plus autologous transplant, and unfortunately relapse under maintenance. And here is the question. At the time of first relapse, PI plus lenalidomide, PI plus pomalidomide, the CD38 plus len plus POM plus proteasome inhibitor, or a second transplant. Now, please vote.
It's beautiful that way.
Okay, I think many people is convinced now that CD38 plus pomalidomide can be a very good option, but also a good proportion suggests plus a proteasome inhibitor. Okay, next question was the patient, as you remember, received DARA-VD, proteasome inhibitor, and progressed 3 months later. And again, here, the response, either CD38 or elotuzumab plus POM plus carfilzomib, or the new agents, selinexor, belantamab, venetoclax, or melflufen. Now, please vote. Okay, half of the audience propose now bispecific. I think very similar to the previous one. People has not moved really, and the majority thinks that bispecific or CAR-T. Then Martin, for you is going to be now the role. But we have questions, by sure, before that.
So thank you so much, Jesus. Very, very complicated choices, but great job. Maybe we can go first. There's questions in the chat box. One is from actually Jack Aiello, who says that for the first question, most of us chose CD38 plus pomalidomide index. Vincent, actually, you chose CD38 and a proteasome inhibitor. This was a patient actually that had the 414 abnormality. So I think it is a reasonable question to say, why would you choose the pomalidomide versus the proteasome inhibitor?
Vincent, do you want to address?
Oh, I think you're on mute, Vincent. We need to unmute.
So for both the questions, I think I was like the outlier, right?
Yes. so pretty normal for
pretty
Vincent.
normal. So for the first one, I chose PI. I think, thank God, 2-3 more people chose PI, mainly because, you know, like between when a patient's refractory to lenalidomide, the two best options in my mind are dara-bortezomib dex and dara-pom dex. And it's really hard to choose when both of them are good regimens and there's no randomized trial comparing the two. I went with the fact that the patients previously had bortezomib, probably tolerated it well, is relapsing on an IMiD. So if I were to completely change two classes of drugs, I would go with dara-bortezomib. The 414 also played a role. So that's why I did it. And I think the patient was treated with my choice, right?
That is a real case.
That is correct.
A real case, and I choose, in fact, for this reason, dara-bortezomib in this particular patient. But unfortunately, 3 months later, the patient progressed. This again reflects how difficult are to treat these high-risk patients anyway.
But the thing is, the second question is more interesting because I think all of you chose bispecific or CAR-T, but you have a patient who's had only dara, bortezomib, thalidomide, and dex. And the patient's never seen carfilzomib so far, never seen pomalidomide so far. You want to jump the gun on two drugs with long track records and go straight to belantamab and straight to CAR-T, which is not realistic for the world? I mean, come on.
Okay. We're looking forward, yes.
No, really.
This was the first one. Then the second, it's the second one that
yeah, the second one
is that Vincent's referring to.
Yeah.
Yes.
This one.
Yes.
Yeah.
Right.
But when I picked PI because you didn't say carfilzomib, but the patient's not at carfilzomib, and we usually, when we have a patient progressing on VRD, we always go to KPD, and that gives you K instead of V and P instead of R, and you know that's standard before you start trying drugs which have still not shown phase 3 efficacy, which have just accelerated approval, and 2 of them, CAR-Ts, are not even approved. So I think you want to use in clinical practice KPD first or DARA-KPD before you go to some of these other ones. I would choose these. These are great options, but I would choose them one line later.
Right. So
I think
a related question is, for the BCMA target, we actually have several choices. We have belantamab, which is already approved, and then we have the bispecifics and the CAR-T. And so they were lumped together in our answers here. So the one question was, how would we maybe select between those?
But Brian,
can I make one point? Sorry, go ahead.
No, but I have a question. Brian, having such a distinguished panel here, I want them to explain me why carfilzomib versus bortezomib showed so good performance in favor of carfilzomib, having double progression-free survival in the Endeavor study, while in the endurance trial, VRD versus KRD are not showing a difference. Therefore, is better bortezomib or carfilzomib is in the relapse setting where the difference is more striking? Can you help me, please? Because I'm a doctor from Spain and I have no many resources, and I want to learn from you.
But I think it's a really important point. And Shaji, I think you have the first stab at this, your trial.
For sure. So I think one of the important differences is the fact that you're using it in combination. So, the brunt of the work is not being done by one drug, whereas, in terms of Endeavor, it's basically everything is riding on one drug. Whereas I think in a combination, the incremental value of that one drug over the other isn't that clear. And we have seen that in Clarion, we have seen that in Endurance. I don't think it's a difference in a relapsed versus newly diagnosed setting difference. I think it's a triplet versus doublet use. I just wanted to again point out one thing, just going back to that case too, is that this is really a very high-risk patient, not because of cytogenetics. Right. This patient got 3 months of response despite getting a VGPR with the first salvage therapy. And that was one of the riding reasons for me to think about something that is different than what we conventionally use and potentially put them on a trial with one of the newer agents.
Yeah, I would echo that and agree with that comment that even with a pomalidomide-based therapy, and I actually wrote in Pomcidex as my triplet to change it. Probably the response duration would be short. It would be 3 to 5 months. So you would be lining them up to get a bispecific or a CAR, or try to get them on a trial, or have belantamab in your back pocket. I will also mention that Jesus said this, that carfilzomib and CD38 antibodies, and both the Candor in the IKEMA trial had very long PFS, not reached at the current time. And that's with follow-up of between 18 and 20 months. So it'll be interesting to see what happens over the next year in terms of what the true PFS is with those, and especially in the lenalidomide refractory population. In the IKEMA study, and Philippe presented this at ASCO, the MRD negativity rate was 30%. It was pretty amazing, actually, for that triplet of isatuximab, carfilzomib, and dex in 1 to 3 prior. So it's pretty impressive.
Tom, does this support the notion that maybe the carfilzomib is more important for high risk and relapsing patients,
I would like to echo Tom's point. At the time of the progression for this specific patient that was very difficult to treat with a very aggressive disease, at the time of the first relapse, I think that the choice of VD daratumumab was suboptimal. Probably with KD dara or KD isatuximab, the results would have been better. And if we are looking at the results of IKEMA and the results of Candor, definitely we are reaching, as mentioned by Tom, 30% MRD negativity, and the data will be updated during this meeting as well. And I think that's really much better as compared with VD Dara.
And Brian, I think one point is...
Vincent, you are mentioning that obviously that's important to try to use Carfil, to use POM before moving to CAR-T or BiTEs. And I agree, fully agree with you. But definitely with KPD, Carfil Pomdex, we don't have any phase 3 data as well. But knowing this patient was refractory to daratumumab, this patient was refractory to bortezomib, to len, and I think that, well, although you are using KPD, your PFS will be very short in this setting. So that's a very difficult to treat patient for sure.
Right. So
right. I mean, like, and I get it. And the thing is, you know, it's very, very easy to say enroll on a bispecific trial or a CAR T trial. It's easier said than done. You want to give the 850 people what you actually will be able to do in practice, which is carfilzomib and Pomdex, and most likely we'll do DARA on top of that to exploit all the synergy. But the other important point that I want to make is that given that a lot of us are moving to DARA Lendex VRD or DARA VRD, the place of carfilzomib and POM really, if you want to use it, will be in the first relapse setting. So echoing what Philippe just said, you know, you want to think of the place of carfilzomib and POM more in the first relapse setting. And then, you know, you can give the best treatment at first relapse rather than waiting for second or third.
I think another important point is that in these patients, either you use the best possible treatment in first relapse or you are lost.
Yeah.
Yeah. Very, very important. Okay. Well, I think that we still do have some questions in the chat box, which we will have follow up on. But I think it's important for us to move forward with our next presentation to keep on schedule here, and moving from early relapse now into triple class refractory and selecting BCMA-directed therapy. Very pleased to welcome Tom Martin from UCSF. So give you control of the slides, Tom.
Thank you, Brian. Thanks, Brian, and thanks, Vincent, for inviting me to present today. I'm going to talk about triple class refractory, or selecting, you know, BCMA-directed therapy. You saw my disclosures. So I'll start with a patient case. It's a 67-year-old male who presented with standard risk IgG kappa myeloma, beta-2 microglobulin 3.4, albumin 3.6, normal LDH, creatinine normal, calcium normal, and FISH just showing hyperdiploid. He has received 3 prior lines of therapy at this time. He had RVD for 6 cycles, followed by an autologous transplant and continuous len maintenance for 36 months, and progresses on maintenance at 10 milligrams daily. Then DARA-KD for 19 months, achieves a VGPR, and then progresses. And really at that point in time, this person is considered triple class refractory because they had len maintenance, they had DARA, and then K. So this person would be triple class. But like Dr. Rajkumar said earlier, we don't give up there. We have many other agents. So we started ELO POM Dex in this person. And they received ELO POM Dex for 6 cycles and achieved a PR. And then PD, and thus has had 3 prior lines of therapy and is now refractory to R, P, K, and D. And so then it goes, then it gives us to this kind of triple class refractory patient. And our options in this patient population are limited. So let's ask you, in your current practice, what would you recommend next for this patient? One, quadruplet combination, using all your previous agents, but combining them maybe in different ways. 2, cyclophosphamide-based combination therapy. 3, selinexor Dex. 4, belantamab mafodotin. 5, a BCMA-targeted CAR T-cell therapeutic. 6, a BCMA-targeted bispecific T-cell engager. 7, a salvage, you have stem cells saved, so a salvage autologous transplant. 8, a salvage allogeneic transplant, or 9, uncertain. So some people would do the triplet or the quadruplet and put it together. A few people would do cyclophosphamide-based therapy. 7% selinexor Dex, and then we have about 0.25% that would go to belantamab in this one. And then the majority of the other people would try to get them on a CAR T-cell trial or a BCMA-targeted T-cell engager trial. with a few votes for salvage allogeneic transplant, and thankfully only 1% for salvage allo transplant. I think it is with these new agents. I think that's really become less of an option these days, and 4% uncertain. Okay. So what did our experts say? Pretty much everybody chose a BCMA targeted CAR T cell trial, except for Dr. Rajkumar. He has gone with the cyclophosphamide based combination chemotherapy, which is still a very reasonable option actually in this case. So I have another question. This goes to really the nature of refractoriness of this disease. So what would your expected survival be in patients with relapsed refractory myeloma, like in this situation that are triple class refractory? Would your expected survival be greater than 2 years? Would your expected survival be 1 to 2 years? Would your expected survival be less than 10 months? If they were penta-refractory, would you expect a survival of greater than 6 months? Or then I put this in specifically for you, Vincent, and that, well, the survival is not measurable because we have such good novel BCMA targeted therapies, they're all going to be cured. And so there is no survival. And then 6 uncertain. So go ahead and vote. Okay, so we have the majority of people picking the triple class refractory expected survival of less than 10 months. And there's where I begin the talk. And that is, so triple class refractory is still the unmet medical need with really poor prognosis. This is the Mammoth study in which several academic centers really evaluated PFS and OS in patients with relapsed myeloma who were refractory to CD38 antibody therapy. And as shown in the figure to the right, patients characterized that as not triple class or triple and quad class refractory or penta-refractory had median overall survivals dismal of 11.2 months, 9.2 months, and 5.6 months. So again, this is a unmet need with really poor prognosis. So here I show, what we have available to us at the current time, the truly available, what's on the left in blue, which is chemotherapy, or now our first BCMA targeted drug, belantamab mafodotin, and selinexor. Those are ones that we can all use. And I would point out what Dr. Kumar voted for, cyclophosphamide, is frequently what is my first choice for all these people because you have it available. And often they have very aggressive disease. And cyclophosphamide, especially IV cyclophosphamide, works really well in this setting. But over to the right in green are the myriad of new drugs that we have in clinical trials at the current time. And I put in dark color what's going to be talked about at ASH of this year. Pretty amazing. We have next generation CD38 antibodies. You heard about iberdomide from Jesus and venetoclax and melflufen. We also have 2 novel bispecific T-cell engagers, BFCR 4350A, which targets FcRH5, and taquetamab, which targets GPRC5D. And you'll hear presentations of that at ASH this year. Pretty amazing. And then we have all our BCMA therapeutics. And honestly, the race is on for which one of these therapeutics is going to rise to the top. So if we look at immunotherapy for myeloma, it's really come a long way. We have a number of good targets, really BCMA emerging as the best target, right? Mostly because it's lineage specific, it spares naive B cells, and you see higher expression on malignant plasma cells. But there are a number of other cell surface targets that are really important and have limited off-target expression, including FcRH5 and GPRC5D. I list on the right the BCMA therapeutics that I think are the closest to coming to clinical fruition. And hopefully we'll be able to use more of these, even in the next year. But the next decade will really be amazing to watch these therapeutics move forward. It's a humanized apoptosis. Yes. No. It utilizes MMAF as its warhead. Susan Trudell originally presented the phase 1 data at ASH a few years ago, showing potent single agent activity. The response rate was actually 60%. albeit in a less heavily exposed population to daratumumab. She also presented data on tolerability, where we first noted the ocular toxicity and also significant heme toxicity, with thrombocytopenia grade 3 and 4 seen in about a third of these patients. This led to the phase 2 DREAM study, which was a randomized phase 2 study for patients having received 3 or more prior lines of therapy and having exposure to IMiDs, PIs, and CD38 antibodies. The 2 doses of belantamab were 2.5 milligrams per kilogram and 3.4 milligrams per kilogram given intravenously every 3 weeks. The primary outcome was overall response rate, with key secondary objectives really being the duration of response and safety. On the bottom of the slide, I showed the key baseline characteristics. This is a very heavily pretreated population, 7 or 6 prior lines of therapy, and really 100% of the patients were triple class exposed. So a heavily pretreated population. And here are the key efficacy and safety data. You see the overall response rate was about 31% in 2.5 and 35% in the 3.4. It was very similar in high risk as well as standard risk patients. I'll point out that the duration of response was 11 months in the lower dose at 2.5 milligrams per kilogram, suggesting that it was better tolerated and patients could stay on therapy longer. And over on the right, I'll point out that there was less heme toxicity in the 2.5 milligrams per kilogram, especially grade 3 or 4 thrombocytopenia, but still a significant amount of keratopathy. About 3/4 of the patients develop keratopathy. So this is available for us now as an agent that we can use. It does require a lot of work on the provider's side. You have to be REMS approved. You have to have the patients go through the REMS. You have to follow together with an ophthalmologist, but it's very doable. And I will tell you that in using this drug, I see some significant responses in patients that I otherwise, a priori would have thought maybe they wouldn't have responded. I haven't gotten a feel of who responds or who doesn't. I think going forward, that's something that we're gonna see in further clinical trials. So for summary in ADCs, what more do we need? Well, we obviously, when we have these drugs that work in the relapse refractory setting, we try to move them up front in an earlier relapse population. We will see a presentation from Suzanne Trudel today, at ASH, looking at split dosing belantamab and together with pomalidomide and dexamethasone. We'll also see a study with belantamab together with bortezomib and dexamethasone presented, as well as further presentations on some of the ocular toxicity and other combinations. And we have a presentation from Dr. Kumar looking at a novel or a new BCMA-directed ADC, MEDI2228, which uses a different toxin, a pyrrolobenzodiazepine dimer. Perhaps will have less toxicity. And I'll also show you that there's one, the STRO or STRO-001, which uses a mitensinoid toxin that's being developed in non-Hodgkin's lymphoma and in myeloma that targets CD74. And there's a presentation, it's on lymphoma, but they're also developing it in myeloma. So we have to look at other targets in this one, and then we have to look at mechanisms of resistance, right? The mechanisms of resistance, especially in ADCCs, are very likely different than the mechanisms of resistance with CARs and bispecific, and perhaps much less dependent on the microenvironment and T cell health and more dependent on the malignant plasma cell itself. We'll just have to see. Okay, well, let's switch gears and let's go on to some CARs. I'm really just gonna show you a spreadsheet of the CARs because we've heard so much of them in the last couple of years at ASH, ASCO, EHA, essentially all our meetings. We're going to have updated presentations of these therapeutics, of ide-cel, BB2121, of BB21217, of cilta-cel, the J&J 4528, and of Orva-cel at ASH this year. You can see that they all show a dramatic overall response rate in relapse and refractory patients, upwards of 80 to 100% overall response rates with these, and as a one dose with significant complete response rates, with, I would say, good median progression-free survivals, especially for BB2121, which is the one we have the longest data on, but not ones that are knocking it out of the park for us. Really, we need more, we need better therapeutics that will provide a longer PFS, right? Now, CAR T-cell therapies are also associated with significant toxicity, right? They come with immune activation, including CRS. You see that CRS grades are between 60 and 90%. This mandates hospitalization essentially for all patients in these products. I will point out some differences, and that is the majority of these CARs are associated with a short interval between the CAR infusion and CRS, typically between 1 and 3 days. Whereas cilta-cel, actually, the median onset for CRS is later. It's at 7 days. And in fact, the majority of patients experience CRS after day 4. And perhaps this will lead to maybe the ability for us to give this CAR initially in the outpatient setting. Dr. Yilin will present more data about CRS later in this meeting with cilta-cel. And I'll also point out that Caitlin Costello from UC San Diego will present updated results from Poseida's BCMA CAR T-cell product. And in earlier presentations, this product has been associated with the lowest CR rates, and in the abstract, a CRS rate of less than 20%, and perhaps could be used as outpatient administration. On the CARs, we have many waterfall plot. But again, this was tempered by these PFS curves, right? Where we see over time after 1 year, 2 year, and even later, we are still seeing relapses for the CAR Ts. So what do we need? We need better manufacturing. We need faster manufacturing. We need better T cells. We need memory-like T cells. We need off-the-shelf products. We need persistence of what I call a good second wave, not the second wave we're all experiencing locally, but a good second wave, meaning when the myeloma starts coming back, we see expansion of the T cells again. We have not seen that yet in any product. And we need to do it in better patients, earlier relapse. In Frontline, there's a presentation of a study that Dr. Usmani is leading in high risk, where we're going to do CAR T cells as consolidation therapy after frontline therapy. And in lower burden disease, we'll have less toxicity, less CRS, potentially less toxicity, neurotoxicity if we do it in earlier line patients. And then we need additional targets. Munchie, who's going to describe biallelic loss of chromosome 16. Together, it seems to correlate with 17p deletions and where there's loss of BCMA and the expression of the myeloma cells. Now, this is the few rather than the majority, but we're going to obviously hear more about this in the coming months and years, the antigen loss. So we still have a lot of work to do with CAR T cells. Okay, so I'll switch in lastly to bispecific T cell engagers. So this is data that Dr. Usmani presented from ASCO 2020 from teclistamab. This is a phase 1. He presented on 76 patients, dose escalation trial. 80% of these were triple class refractory, so a very heavily pretreated population. In terms of toxicity at the higher doses, 60+% of patients are having CRS, but a small amount of neurotoxicity. And if we look at responses, we're actually seeing an overall response rate in 12 patients treated at 270 micrograms of 67%. And if you look at the swimmer's plot on the right, we're having some durable responses. People are staying on and responses are deepening over time. Actually pretty amazing from this. But at ASH, we've heard of 3 prior presentations that have excited us. AMG 420, the BMS drug CC-93269 and teclistamab, these early presentations showing response rates of 60 to 90%. But at ASH, we're going to have 6 more. We're doubling the number of prior presentations at this ASH. And I think Dr. Usmani quoted it as the prom queen, the bispecifics are the prom queen of ASH this year for myeloma, that this is where a lot of the activity is, which is really, really amazing. And it's going to be fun to watch these go on in the next few days. So what do we need more for bispecifics? Well, we need phase 2 results. And obviously the race is on to the first one being to market. We need to optimize the step-up dosing, make it easier. for us to give it, potentially be able to give it as outpatient administration. Maybe we could give prophylactic tocilizumab, or maybe we can give steroids or other ways to mitigate CRS, so it can be all outpatient. We also obviously need additional targets, and I talked about that. And then we need to use these in combination. And so you're going to soon see combinations of bispecifics with INTs and CELMoDs and PIs and other next generation CD38 antibodies. Again, the combinations are going to be really interesting as we move forward. So in conclusion, I will tell about some advantages and disadvantages. And that is, so some of these actually are off the shelf. And that is a major advantage. And it's a major advantage to the way these drugs are going to be used, especially in the community. And drug conjugates are off the shelf, and you can give it at any infusion center in the outpatient setting. CARs and BiTEs are likely going to require hospitalization. They come with a little bit more overhead. CARs also, they require FACT accreditation, and they require significant social support for the patient, right? And they're also quite expensive. So we'll see what develops in the next few years in terms of the advantages and disadvantages. All right, so as of now, in terms of sequencing, we have belamaf, and I think it's a perfectly good choice for patients that have triple class refractory multiple myeloma. In first quarter of next year, there's going to be a choice. We're going to have a BCMA targeted CAR T. We're going to have ide-cel likely approved. Its PDUFA date is in end of March 2021. And so we're going to have to choose between the two of these. Now, Dr. Nikhil Munshi and the IMS is trying to put forward guidelines of who should be sent for evaluation of CAR Ts. And we look forward to seeing those guidelines. But I'm going to shorten it and tell you that for BCMA targeted CAR Ts, they have to be fit. They have to be well resourced, meaning they have to have people that can support them and they can come to the transplant center or the CAR T cells center, and they'll need to be triple refractory. For belantamab, less fit, limited social support, and they actually we can use it in patients that are rapidly progressive. CARs are not good for patients that are rapidly progressive. And in the third quarter to fourth quarter of next year, we'll have a second CAR T. And that'll make it even more difficult for us to make our choice. And then next, in 2022 and beyond, wow, we'll have many CARs, several BCMA and targeted ADCs, and I suspect several bispecific T-cell engagers. And I'll just show this, my final slide, in that the map of future strategies. I think we're going to get to quads as frontline. We're going to be doing CARs or BiTEs as early relapse. And then in late relapse, we're going to need off-the-shelf products, third-party cellular therapies like allogeneic CARs, NK CARs. We're going to be using CRISPR strategies, et cetera. And really, it's going to be an exciting time. Okay, and that's it. Thank you very much for your attention.
So thank you so much, Tom. So let's go ahead and look at your case again and take a vote.
Okay, so we have a triple class refractory patient. And the vote is, are you going to mix all your medications together? Are you going to do cyclophosphamide-based combination chemotherapy, selinexor and dex, belantamab mafodotin, or a BCMA-targeted CAR, a BCMA-targeted bispecific, a salvage transplant, a salvage allo transplant, or again, you're uncertain? Hopefully you're not uncertain. Jesus, we need the music.
Yeah. Yeah. Oh, here we go. It's faster. So.
All right. Well, people are impressed by the BCMA targeted CAR, and we have a few extra people picking belantamab because belantamab is off the shelf and we can give it right now. And maybe a few less chose the bispecific T-cell engagers. Maybe because it does require a hospital stay. And, you know, we are quite a bit away. We're a year plus away from the BCMA targeted bispecific therapeutics. So Brian, I'll hand it back to you.
Well, thank you so much, Tom, for that comprehensive review of the really, really exciting immune therapies. Maybe the first comment, there's a lot of comments about choosing between belantamab, which is currently available, a CAR T, or a bispecific, you know, how do you kind of choose? If you have a patient, would you direct them towards one of those three? You know, you had a very nice slide where you showed the advantages and the disadvantages. So it covers quite a number of the questions here, but do you want to comment a little more on that?
Yeah, absolutely. So, you know, the eligibility for CAR, I think, is a broader eligibility than it is for even a autologous transplant. I think more people can tolerate a CAR than can tolerate an auto transplant, but it does come with the need to go to the center that does them. And that's actually going to be, I think, a limiting step. And we know from the lymphoma crew that are ahead of us by a year or two in terms of standard CARs, that a far minority of patients who are eligible actually get to the center to get their CAR therapy. So we have to work on that. But in a young, fit, otherwise okay person, I would certainly like to see them potentially to give them the CAR therapy to make a decision between belamaf versus the CAR T decision before they get belamaf. We don't have any data about CAR T administration after patients have received belamaf at the current time. No significant data. So that I think for a young, fit person that can do it, they should be referred for a CAR T evaluation. In terms of an older patient or somebody rapidly progressing, and that's a lot of our patients relapse or refractory, I think you can get them on belamaf, and then if they have a response and are doing okay, I would then refer them for what's next, because those people, again, the duration of response tends to be less than a year. You want to have the next thing ready to go for them.
Right. So good discussion. Anyone else like to comment on that?
Tom, thank you very much. I think it was a very comprehensive presentation. I have a question about life after CAR Ts. We are seeing that patients that theoretically go for CAR Ts are patients that has no other options. By contrast, after relapsing a CAR T, some patients respond to previous therapies. Can you elaborate a bit on this?
Yeah, absolutely. So there's not really a lot of data. There's more individual case level data, right? And so we have a number of patients here, even at UCSF, patients that I have treated with Dara-Pom-Dex going into CAR, and maybe have had a 4 to 6 month, duration of remission, and have relapsed a year or 2 years after CAR, and I put them back on Dara-Pom-Dex, and they've gotten 2 years off the Dara-Pom-Dex. So we are seeing these inversions that are unusual. Now, I don't know what the explanation of that is. It because they've been off therapy for 12 months or 18 months, and they have better T cells that are now in the microenvironment of their marrows, et cetera? I think these are things we need to figure out, and is going to be, I think, a big part of further studies and looking at single cell of the microenvironment, et cetera. But certainly there's plenty of patients that we've heard of that have that inversion.
Right. Even this disconnect between the early PFS, which can be around a year, but these patients seem to have ongoing survival, which is...
This is a very important point, Brian, because when we are speaking about patients that are triple class refractory to PI, IMiDs, and CD38, many of them did not receive POM, or many of them did not receive carfilzomib, as we discussed previously. And we are going to hear during this meeting some results that are not surprising, but as you're mentioning, PFS of 1 year, but an overall survival of 2.5 years, although they were supposed to be refractory. It means that those patients are not refractory. And many of them did not receive as well alkylators. So we have to look very carefully at the sequence and the drugs that were used before claiming that a patient is totally refractory to all drugs available. And for example, POM, cyclophosphamide, and DEX, that could be an option. Carfilzomib, cyclodex, as discussed by Marivi during this meeting, as well, will be quite interesting.
Yeah.
Important aspect is many of these trials require patients to stay, the screening time is so long, and then the gap between the apheresis. And one common thing amongst all these phase 2 trials is the number of patients who drop out between the initial registration and finally getting the CAR T cell. And that's an important point too.
For sure.
Right. There is a preference for patients who can get through that waiting period, the bridging period. Yeah.
So Brian, can I make a comment since I was again the odd one out with cyclophosphamide?
Absolutely.
This is what Jesus said last year. He forgot this year.
No, because I would propose with melphalan.
No, patients have gone through, like in this particular patient's case, VRD, I don't know what all, DPD or KPD, and then ERD, and you had bortezomib, lenalidomide, pomalidomide, carfilzomib, all refractory, but the patient's never seen alkylators. And you know what happened in the FOCUS trial, even whether the patients respond or not, they can go 10 months on just on cyclophosphamide alone without a novel agent added on. But we can actually do CyBorD, we can do KCD, and get the synergy with the PI and the alkylators. And that seems to work even in patients who have been refractory to PIs alone or PI plus IMiD. So I think, again, realistically, except for a few people in the United States, very few people can easily get a CAR T or a bispecific. Even belantamab is not that easy to just get on a dime. So I think we need to make sure people understand that there are good alkylator-based combinations that you could use, whether it's palm-cyclodex, carfilzomib cyclodex, or bortezomib cyclodex, that can all easily give you that 8-10 months you need to work. I mean, the BCMAs are not going anywhere. They're going to be around for your patients, but it's hard to get them immediately. So keep that in mind.
We're going to have to move ahead, Vincent, but I think these are really, really important points. And the key thing is that I don't know how many sites there are going to be for CAR T. I'm hearing maybe 70 or 80 sites, maybe across the US, where you could maybe go to get a CAR T cell therapy. I mean, so we need to look more closely at what the alternate options are to get patients through. Very, very, very important. So, Tom, any closing thoughts before we have to move on? Actually, we move on to you, Vincent, who will be discussing the future. Any last thoughts, Tom?
Well, I would say there's a lot of questions in the chat, and actually some really good questions about subcutaneous dosing and step-up dosing, et cetera. And what I'll say is, if you follow all of these presentations at ASH, you are going to answer most of your questions that actually came up in the chat. There are so many presentations on bispecifics and CARs and updates, and even on belantamab. Just follow those abstracts and you're going to learn everything about your questions from the chat, which is pretty amazing, actually.
Absolutely, yeah. And you covered a lot of the questions, as a matter of fact. So, all right. Well, thank you so much, Tom, and for our comments and follow up. So let's move toward Vincent with the next presentation.
Well, thanks, Brian.
Oh, here we go. Yeah, myeloma future directions, and yeah, go ahead.
So I'll try to keep it brief because Dr. Martin and Dr. San-Miguel really summarized a lot of the new advances, and I don't need to go through the details. This is more supposed to be a brainstorming session and a discussion, and I'll keep it short so that we can probably get through some of the questions and also discuss amongst the 5-6 of us. So the first thing is, like, we have a lot of options coming up, and these are all the ones that I'm mentioning today are all drugs that are not yet approved, but I think they might get approved, and I'm going to classify them so you can see what the options that will be coming up in the future. And also it'll give you an idea of what the pros and cons would be. So first, we have we already have 2 CD38 antibodies, daratumumab and isatuximab. And there are at least 3 other CD38 antibodies that are in development. And I think the main role of these multiple CD38s would be that there might be patients who respond better slightly to one or the other, but it's just multiple choices. You already heard from the panel that, when carfilzomib first came, we were all like, oh, we've got carfilzomib, even though we have bortezomib. And same thing when pomalidomide came. But today, people are reluctant. People are saying, like, why use carfilzomib or pom? We'll use the new one. So things change as we have more options. So when these 3 new anti-CD38s come, I don't know what place they will capture, but I would direct you to an abstract that's at ASH, abstract 721, which shows how easily resistance can develop, in this case to BCMA, but also to CD38 antibodies. It's surprising that a plasma cell that expresses CD38 will still become resistant to daratumumab. And there's an abstract at this ASH looking at isatuximab in patients who've had daratumumab before. And really, you don't have that much new responses that you get. So multiple CD38s coming, but I'm not sure the place of how one will take over from the next. Newer IMiDs or newer CELMoDs, iberdomide, CC92480, they've all shown promise. Here you can see in this picture the way binding to cereblon occurs with lenalidomide on the left-hand side and with iberdomide on the right-hand side. It's just a more tight binding and hopefully better inhibition of cereblon and therefore better effect. We don't know, again, the proof would be how well these drugs respond in patients who are bona fide refractory to lenalidomide and pomalidomide. Then we have bispecific antibodies that are targeting BCMA. And again, here the whole thing would be between the ADC BCMAs, the bispecific BCMAs, and the CAR-T BCMAs. How will there be overlap? Would there be resistance to one when the other one fails? And how often or how likely are you to get a durable response with the other one? Those are all going to be unanswered questions that we have to answer. But thank God we have a number of bispecifics that are coming up. We have teclistamab this year presented at ASH. AMG 701 presentation is at ASH, and the 93269 as well. These bispecifics all bind to BCMA as well as CD3, and that's how their mechanism of action is. The problem is that, as I said before, what if you lose BCMA? Or what if you've already had a CAR-T against BCMA or an ADC? Then would these bispecifics still work? And that's where the bispecifics that are targeting a different antigen besides BCMA come in. And we have a couple of them this year presented at ASH. One is BFCR4350A by Dr. Cohen, which is a bispecific targeting FcRH5 and CD3, and then talquetamab targeting GPRC5D and CD3, presented by Dr. Chari. I would encourage you to look at both of these very high response rates in refractory populations. And this gives you an option of going beyond BCMA. We have like 7, 8 different treatments with the CAR-Ts, with the bispecifics and the ADCs targeting BCMA. We need something besides BCMA. And these give us that, that possibility, and very promising at that. Even CAR-Ts, there's many that are trying to see what happens. I mean, what can we do since there's a problem with the timing? There's also the problem with the antigen, like, you know, what if the patient's already refractory to BCMA or doesn't have BCMA expression? And so there are multiple CAR-Ts that are using different strategies. And at ASH this year, you have the allogeneic CAR-T that Dr. Shammal and Cody is going to present off the shelf, again, abstract 129 that you should look at. And in prior meetings, I think in the last meeting or the meeting before, we've had CAR-Ts that target CD19, CAR-Ts that are combined CD19 and BCMA, CAR-Ts that are multi-antigen targeting, individualized targeting, as well as CAR-NK. So there's a different set of CAR approaches that target other antigens besides BCMA and also multiple antigens that would all play a role for us. So what does the future state looks like? And you know, this is really, I have written multiple relapse, but you can see if you have a patient on DARA VTD, they would be in the refractory to IMiD, PI, and anti-CD38 category at first relapse, right there. You can have patients getting DARA VRD soon in the US, and you might end up with the same situation. So we have to look at what options do we have if people are bona fide refractory to IMiD, PI, and anti-CD38. And that's where I mentioned that there's a lot of us have to think about cyclophosphamide or alkylator-based combinations, because they are still good options and they can still be partnered with other drugs that the patient's not refractory to, and get your response. But if you don't think of cyclophosphamide, as you saw many of the expert panelists today mention, the anti-BCMA strategies, whether it be an ADC like belantamab, whether it be bispecifics that you're going to have coming up soon, or BCMA CARs, a lot of BCMA-based strategies would be the two options would be alkylator-based and BCMA-based. But again, you could blow through these within 1 or 2 relapses, and you will end up with a patient within 2 lines or 3 lines who's already refractory to IMiD, PI, anti-CD38, alkylators, and BCMA. Then what do you do? And again, we have drugs that we have not exploited to their fullest potential, and we need to develop rational combinations. And I've been advising people that you have to look beyond. Like, for example, selinexor. It's an XPO1 inhibitor. It's good. The data we have is for selinexor alone or with selinexor bortezomib dex. But if the patient's already refractory to bortezomib, they're already penta-refractory to these 5 things when they come to this stage, you need combinations of selinexor with other drugs that they're not refractory to, not with bortezomib, not with pomalidomide, with the patient's already refractory to. You wouldn't trust selinexor alone for a patient who's already refractory to 5 of these drugs. So we have a lot of combinations that we can create and exploit using drugs that are already available: elotuzumab, selinexor, venetoclax, panobinostat, bendamustine, and anthracycline-containing regimens. These are available, but they're now partnered mainly with drugs that patients would already be refractory to when you come to that stage. And so a lot of data needs to be generated with these drugs. And then on the right-hand side, you have brand new drugs, new monoclonals, iberdomide, CC94480, new ADCs, new bispecifics, and new CAR-Ts that I just mentioned that are totally new, that are different class than any of the ones that we have right now, and hopefully will give us the path forward. I'll close with this, and we'll have a panel discussion before we go to the algorithms. Thank you.
Absolutely. Thank you so much, Vincent, for that sort of overview of where we are. A lot of choices, but very, very helpful perspective. So any thoughts or comments from the panel?
I think Vincent alluded to this, but I think the challenge is going to be how you're going to position these. And obviously, the phase 3 type data will take a long time to come through. And where we have data for phase 3 would be the monoclonal antibodies, PIs, and IMiDs, and they're going to occupy the first 2 lines of therapy until we have these ones show positive results in trials, which would be a few years from now. And I think it asks for 2 things. I think one is obviously we may have to relook at how we are doing clinical trials. How much of evidence do you need before something moves upfront? And I think if you have really strong data in the relapse setting, do you really need a 800 patient trial to tell you that drug is something that could be used early on? And I think as a community, we have to start looking at designing novel ways of doing clinical trials to get these things earlier to the patients.
So Shaji, are you talking about phase 2 trials of some combos similar to what Vincent was talking about to bring in some of the newer drugs like selinexor or elotuzumab with a combination and get some strong phase 2 data?
Right. And I think we had looked at designs of multi-arm phase 2 trials, which would look at different combinations. And I think we probably need to have different thresholds for saying, okay, this is something that looks the most promising out of these 6 different combinations. Right. Let's do something much ahead of the others. And I think the luxury we have now, which we didn't have before, is we have multiple different things to choose from. Before we had like 1 or 2, and we really wanted to make sure that comes forward. So we were willing to take a lower bar for those to get across.
Right.
Yeah, I would agree with that. And the data is with such high response rates for these bispecific T-cell engagers and the CAR-Ts, we're going to want to move them further, in earlier relapse and even potentially in frontline. So we are going to have to have different endpoints for some of these. And it might be easier for us, and I think we all think this, that to start the development in the high risk, patients that we don't expect to actually make it to that 6-year or 7-year time point in remission, like for, DARA RVD. And so, I think those studies are just starting. And then, these are single agent studies that we're talking about in relapse refractory. When we start combining them with cell mods and the other stuff, it's going to be pretty impressive on how durable these responses are going to be.
Absolutely, absolutely. A question coming out of the chat box, which we haven't touched on much, is where do we think melflufen could fit into the picture? Do we see that, as a combo that could be useful? Anyone want to comment on that? It's been on several of the slides, but
I mean, Jesús, go ahead. Sorry.
No, I think Vincent has already alluded to the alkylators, and we need really good because alkylators works in myeloma. The problem is that at the time of relapse, some alkylators such as melphalan that could be very valuable, the bone marrow reserve is poor. And this is a challenge. And this is the reason why cyclophosphamide has become more popular. Right. And if melflufen is able to reduce the myelotoxicity, could be very attractive drug for combination in many patients, because we know that melphalan can be combined in different settings. And this is an area that should be explored. There is another point that I would like to raise is we are talking about fancy drugs, all our centers have the capacity to offer patients bispecific CAR-Ts, and we doubt to use one bispecific, the other the CAR-T, but a large part of the audience have only access to 2, 3, 4 drugs, no more than that. And I think it's also our duty just to develop cheap combinations. Now some of the drugs are becoming generic, and to make good combination with such generic drugs will be important for developing countries.
Yeah, I fully agree. And this type of trial that you were talking about, Shaji, maybe to have a multi-arm phase 2 trial to look at different combinations could help generate enough data. Yeah.
Brian, another point that I will like to raise for the panel is about the high risk and the results that are referring for high risk. If I compare whatever triplet versus a doublet in high risk, probably the hazard ratio is going to be very good. And this is the message is usually reported is even better, higher hazard ratio in the high than in the standard risk. But this is not the data that I'm looking for. The data that I'm looking for is the progression-free survival in the high versus the standard risk with the triple combination, not the comparison of the triple versus the double. And this is sometimes misleading in some of the presentations that we have.
Very, very good point. Okay. So I think that we're running long on time here, but I think that we come to the important and I think quite popular segment of the program where Vincent and Philippe review the proposed algorithms for 2021. So if we can move into that now, and I believe we'll be starting with Vincent. Or Philippe is fine. Is it Philippe first? Okay.
No, that's Vincent.
Right. Okay. Brian, thank you. And before I start, I just want to make sure we usually tell people, we prefer that people don't follow these algorithms, that you put patients on clinical trials, because the algorithms are to be used when you don't have a trial and you're wondering what is the general standard of care. But we believe that all myeloma therapy is still experimental because we have a long way to go. We still want to cure our patients, and we want better induction therapies, better newly diagnosed therapies, better first relapse. So as far as possible, you want to enroll your patient on a clinical trial. And good news is that there are many of them available, and many of them are available at multiple centers closer to you as well. So try to do a clinical trial, and these algorithms are only to give you an idea of what to do if a trial was not available, and also to give you a framework. I mean, if you know the basics, then you can deviate from it. And so this is just the basic understanding of where we are. And then you will have your own patient that you will individualize treatment and change. So this is not written in stone. And what I'm saying is here for this first algorithm is we have heard a lot about smoldering myeloma or potential. A patient doesn't come advertised as having smoldering myeloma. You have a patient who has a monoclonal protein and a certain amount of bone marrow plasma cells, and you're wondering, does this patient have myeloma or not? And whether this patient has smoldering myeloma or not. So that's the clinical situation. And in that patient, you do your workup. And if the patient has any myeloma defining event, I don't think any one of us is going to quarrel with you that that patient needs therapy for myeloma. If the patient does not have myeloma defining events, but has a bone marrow that's 10% or more involved, you're thinking smoldering myeloma. Now you want to classify the patient into high risk or low risk. The easiest way to do that is the 2-20-20 system, which has been validated by the IMWG. If you're able to follow the scoring system, that's even better because you'll get a more precise estimate of what the risk is. If your patient has high-risk smoldering myeloma, it means that there is a 50-50 chance that they'll progress within the next 2 years. Then we all recommend that that patient receive therapy with either Len or Lendex or clinical trials. Now, clinical trials is preferred. That's why it's in blue. Now, there are patients here with the scoring system, you may reach the level of newly diagnosed myeloma, in which case you would treat as myeloma. On the other hand, if the patient does not have any high-risk features, the standard of care remains observation. So again, the blue is what's a preferred route. Now, in newly diagnosed myeloma patients who have symptomatic myeloma or myeloma-defining events, if they are not transplant candidates, you heard from Dr. Moreau that DRD is a great option. And I still maintain that VRD for 6 to 9 months followed by Len maintenance is a great alternative. Whichever one you're able to do, I think your patient will do well. They will get you a PFS of 3 to 4 years or longer with either of those approaches. If the patient is a transplant candidate, then you want to give induction therapy for about 4 months, followed by a stem cell transplant, followed by maintenance. And that's the preferred route, and that's shown in blue. There are some data emerging that a quadruplet like DARA-VTD or DARA-VRD may be useful in selected patients. We at Mayo mainly use it for high-risk patients, but that's an emerging option. As far as maintenance goes, most of us would do lenalidomide as the maintenance for all patients, but we may add bortezomib for high-risk patients. At this ASH meeting, there is the 8-year overall survival data being presented by Michel et al. And his group. Ori Peroro is presenting, I think. And the data show that the 8-year overall survival rate is identical whether you do a delayed transplant or an early transplant. But you have to do a transplant, or you have the intent to do a transplant. That's critical. And so for selected patients, if the patient preference is very strong, they have standard risk disease, you could consider just 4 more cycles of VRD, Len maintenance, and a delayed transplant. Philippe, you want to take it in terms of the frontline therapy?
Yes, Vincent. Well, I wouldn't claim that this is the European approach. I wouldn't claim that this is a European approach, but that's very, very close to your proposal, Vincent. For patients that are not transplant candidates, we are favoring DRD, and we are also favoring VRD followed by lenalidomide maintenance. And we know that drug access is very important. The cost is very important, as discussed previously. We have other options that are available, and VMP-DARA is a good one as well, based on the overall survival benefit of Alcyone, and Lendex is remaining an option, especially for frail patients, for sure. For those patient transplant candidates, we are favoring VRD as induction or DARA-based quadruplet induction, If VRD cannot be used, you know that VRD is not yet approved before stem cell transplantation in Europe. And in some countries, we cannot use VRD. We can use as a second option VTD or CyBorD, VCD, that is also associated with very high responses. And then we are proposing systematically in Europe autologous stem cell transplantation with maintenance based on lenalidomide for standard risk or len plus proteasome inhibitor-based maintenance for high risk. In some cases, we are preferring bortezomib-based maintenance for high-risk patients. And we discussed previously the role of tandem outside clinical trials for patients with 17p, for example. We are not favoring delayed stem cell transplantation in Europe, but as you mentioned clearly, Vincent, we have to hear the results of the IFM 2009 results with a very, very long follow-up showing no overall survival difference, but still a benefit in terms of PFS and MRD negativity rates as well for frontline stem cell transplantation. So our proposals are very similar to yours, definitely.
Well, thanks, Philippe. And I would also agree with you on the tandem for high risk. At the Mayo Clinic, our guideline also says to consider tandem transplant for deletion 17p high risk. Right, Shaji? At present, our thing. So very, very closely aligned. For first relapse, again, there's just so many options. A lot of the options depend on what the patient has received previously and what kind of relapse it is, whether it's symptomatic or asymptomatic, and also, how did they tolerate the previous regimen? But clearly, if you had to come down and choose one, then if the patient's not refractory to lenalidomide, the Pollux data with DRD seem outstanding with 44 months PFS. If the patient's refractory to lenalidomide, then we heard already that you could either use a DARA bortezomib dex or a DARA pomalidomide dex, and it's really a toss-up. We have another antibody that's approved, isatuximab pom dex, and I would suggest that you look at economics there in terms of which of the three would offer the patient the lowest cost out of pocket, which would be the lowest cost to society, and those factors also, because I think it's a toss-up between those three regimens. On the other hand, you could use any number of other ones as well. Basically, carfilzomib-based regimens for DARA particularly if they're DARA refractory, they've already received DARA in the front line and they're getting DARA RD and progressing on that. Carfilzomib-based regimens become very important, particularly KPD, KRD, and then you have other options, including ELO-based regimens and ixazimib-based regimens, particularly for frail patients. Philippe, you want to comment on these?
Yes, in fact, and again, we are very, very close in terms of proposal. When patients are not refractory to lenalidomide, definitely DRD at the time of the first relapse is the best option. You mentioned Pollux, and especially first relapse, the PFS is almost better than 4 years. We have other possibilities, including KRD, Ixalendex, Elolendex, as discussed by Jesús as well. But now we see that we have other possibilities with KD, and we can add a monoclonal antibody on top of Carfildex, KD Dara, KD Isatuximab, definitely very good results based on Candor and IKEMA. And we are going to hear about the analysis of these two trials during this meeting. But when patients are refractory to lenalidomide, we can use the switch from an IMiD to a PI. And in this setting, KD Dara, KD Isatuximab are very good options, not yet available everywhere. But we can also use POM-VD. The optimism study published by Paul Richardson is quite interesting for those patients refractory to len, first relapse. The median PFS is 17 months, as recently published by Thanos Dimopoulos. We are going to hear during the meeting of the POMDEX daratumumab option. The Apollo study will be presented as an oral presentation during this meeting, that's also a good possibility. And we know that Pomdex isatuximab based on Icaria is also interesting for patients failing not only LEN, but failing bortezomib as well. And we have other proposals that you discuss as well. I put here Pomcyclodex for frail patients, ixazomib Pomdex as well. But my last comment is we will have to face the challenge of patients failing frontline daratumumab. That will be something that we have to anticipate. When patients will receive DRD frontline, what will be the best option? For sure, they are going to fail LEN plus daratumumab, and the logical approach will be a PI-based regimen, but this is something that will come very soon as well.
Thanks, Philippe. And then if I want to emphasize one thing, particularly this is true of the United States, with a lot of patients choosing transplant at delayed, you really want to think as the transplant that you saved the stem cells for as the first relapse option.
Definitely.
So I have that written down. Consider salvaged auto transplant in all eligible patients, because many times these patients have had stem cells stored for delayed, and you want to use them. And it's always best to use the transplant earlier than waiting for fourth relapse or fifth relapse. Similarly, if the patients had an extremely good response to the first transplant, they had a transplant and they've gone 5 years, 6 years, and you've had stem cells stored and they are still eligible, I think you might want to use that now rather than keep that for later. So that's one point I wanted to make. And then when we go to second or higher relapse, it's really like, as you see, every day we get a new regimen, a new drug. So it's going to be very hard to tell people what to do. All I'm going to leave with you is principles that you're going to try and use 2 new drugs that the patient's not refractory to, so that you can use them in combinations. Of course, with some of the new drugs on trials, you may be having to use it as a single agent. But if you're able to, 2 new drugs that the patient's not refractory to, along with Dex, that forms the triplet. And so any of the first relapse options that have not been tried can be used. And then you have a whole host of additional options that you can use in sequence. And I don't think you make a major mistake using, say, one regimen before the other or the other before this one. I think as long as you give all of the options that are available to the patient, you will get the best outcome. And sometimes just getting a good outcome for a year is great, because in a year we may have another 2 or 3 options show up. So be optimistic, and I'm glad we have many new treatments that are going to be presented this year at this ASH meeting. And we're looking forward to those data in the next 2 or 3 days. So Philippe, did you want to comment on these?
Yes, in fact, very few comments, because I agree with you regarding the use of options that have not been tried. For sure, we are preferring triplet if possible. We have to evaluate carefully the options that were used in the past and the drugs that were never used. We are discussing carfilzomib, pomalidomide, but alkylators. And definitely additional options. Belamaf is approved in the US and in Europe as well for patients failing IMiDs, failing PIs, and CD38. In Europe, we have to restrict the use of Belamaf after 4 lines as an option after 4 lines of treatment. So definitely it is approved. In the US, you can use selinexor, not yet in Europe, but we have some compassionate use program to have selinexor Dex for patients triple class refractory. I did mention combinations of conventional chemo. We don't have any phase 3 data for very, very advanced patients, but it can be of benefit definitely. And I mentioned cyclophosphamide, bendamustine, melphalan as well. In some cases, that's interesting to use this agent, panobinostat, that is able to revert proteasome inhibitor resistance. I mentioned as well, like venetoclax for patients, only for patients with 11-14. In routine, we are not testing BCL2 high expression, but venetoclax is also improving the outcome for this subgroup of patients. And definitely in Europe, we cannot have access in routine to melflufen, CAR-Ts, bispecific. We are proposing clinical trials for these new agents.
Excellent. Brian, that's all that we had,
Yeah,
Philippe and
great.
I.
So I think that's really, really good. And so the algorithms really speak for themselves, you know, and you've discussed them quite nicely. There's only actually one question in the chat box which we can take care of, which is harvesting stem cells in patients being treated now for high-risk smoldering myeloma, which is interesting. I think that we can just say that we handle that pretty much the same way as you would treating a patient with myeloma. For example, in the ASCENT trial, we harvest the patients if they would be transplant eligible. So just to comment on that. But as we are evolving through the treatment of high-risk smoldering, a lot of different issues are in fact emerging as to, you know, whether they would be eligible to get into some of these relapse trials and things like that, if they've never actually had myeloma per se.
Brian, we managed to keep 735 people online for 3 hours.
Yes, this is, we greatly appreciate that, but I think it's largely due to you guys. I think I would personally like to thank all of our presenters on behalf of the audience today. I think all of the presentations have been really fantastic and has led to some really helpful discussion, which Vincent, you've kept us on track, making sure the discussions are practical, you know, and help people who might not be able to get CAR-Ts or things like that. And we get a comment here that we kept them here even without providing lunch, which is true. You have to get your own lunch. So I'm getting comments that the audience has really appreciated as well. Any final thoughts from our panelists for today? We're obviously looking forward to a new experience with virtual ASH.
Right. Brian, if I may, my colleague, as we were speaking, Chadi, who's a great lymphoma specialist, he just sent out an invite. Any one of us who wants to join us for a Zoom hangout during ASH, Monday evening, 6 o'clock Central Time, just email us and we'll send you an invite and we can chill.
Okay, we bring your own wine, huh?
Bring your own wine.
Yeah, and music. We need music. Maybe we can. Well, you guys, we know that Vincent and Philippe, you can provide some music for us. Okay.
There you go.
So a final point for the audience is that to get your credits and to download the slides, you can certainly do that. And we do appreciate evaluation. So if you want to fill out the evaluations, we always pay attention to the feedback and try to really improve each year and keep the presentations as excellent as possible. So thanks again. Thanks to panelists, thanks to our sponsors, and we look forward to ASH, and we look forward to a real meeting next year.